LDN Primer 2026 edition. LDN Primer 2026 edition. Yoon Hang Kim, MD. LDN Primer 2026 edition. By Yoon Hang Kim, MD. Copyright Yoon Hang Kim, MD. Yoon Hang Kim, MD, www.yoonhangkim.com. Low-Dose Naltrexone Primer, A People's Medicine for Chronic Illness, 2026 edition. By Yoon Hang, John Kim, MD, MPH. Prologue, A People's Medicine. Part 1, Understanding LDN. Chapter 1, Meet Low-Dose Naltrexone. Chapter 2, 3 Reasons I Use LDN. Chapter 3, How LDN Works, Endorphins, Microglia, and the Immunoadaptogen Idea. Part 2, Who LDN Helps. Chapter 4, Conditions where LDN is used. Chapter 5, Long COVID, Mold, Lyme, and MCAS. Chapter 6, LDN and Cancer, An Honest Look. Chapter 7, LDN for Children. Part 3, Getting LDN Right. Chapter 8, Finding the Right Dose. Chapter 9, When Standard LDN Doesn't Work. Chapter 10, Side Effects and How to Manage Them. Part 4, Working with your doctor and yourself. Chapter 11, Finding a prescriber and talking to your doctor. Chapter 12, What to expect in the first 90 days. Closing. Chapter 13, The Honest Truth about LDN. Postlogue, A Note of Gratitude. Prologue, A People's Medicine. I did not set out to become an LDN doctor. The path opened, the way most meaningful paths in medicine do, through a patient. It was just over 20 years ago. A woman with Hashimoto's thyroiditis sat across from me in my office. She was tired in the particular way that autoimmune disease makes people tired, the kind of tired that sleep does not fix. She had been doing her own research the way patients increasingly do, and she asked me a question I had never been asked before. Have you heard of low-dose naltrexone? I had not. I told her I would look into it. What I found surprised me. Naltrexone, I knew. At 50 milligrams, it is a workhorse medication used to treat opioid and alcohol dependence. I had prescribed it during my training. But low-dose naltrexone, LDN, was something different. At 1/10, the standard dose or less, it appeared to do things the textbook could not easily explain. It calmed the immune system. It reduced inflammation. It helped patients with conditions that had stumped conventional medicine for decades. The side effects were mild. The cost was almost nothing. The pharmacology fascinated me. The clinical reports compelled me. And the patient sitting in front of me deserved a real answer. I started reading. I did not stop. That was the beginning. 20 years later, LDN has become a cornerstone of my practice. I prescribe it for autoimmune disease, for chronic pain, for the long tail of post-infection syndromes, and for inflammatory conditions where conventional treatment has fallen short. I have watched it return function to patients who had nearly given up. I have also watched it fail in patients I was certain it would help. Medicine is humbling work. No tool, however good, is universal. Along the way, I have written books, journal articles, and blog posts. I have spoken at international LDN conferences. I have taught other physicians how to prescribe it. But the most surprising part of this 20-year arc has not been the medicine. It has been the community. I have had the honor of hosting the LDN support group through ldnsupportgroup.org, our companion Facebook group, and our school community, together. They serve more than 10,000 members across the globe. These are patients, caregivers, clinicians, researchers, and curious minds. They share what works and what does not. They challenge my assumptions. They remind me every week that medicine is at its best when it is a conversation rather than a pronouncement. This book is the result of that conversation. I call it a people's medicine because that is what LDN has become. It is not a medication owned by any drug company. It is not the subject of glossy ads or sales reps. It has spread the way a recipe spreads in a kitchen, patient to patient, doctor to doctor, story to story. The peer-reviewed evidence has caught up over time. The trials are now real and growing. But the heart of LDN's growth has always been the people who tried it, told their friends, and asked their doctors. This primer is for them. It is also for you if you are wondering whether LDN might help you or someone you love. I have tried to write the book I wish I could hand every patient who walks into my office asking about LDN. It is honest about what LDN can do. It is honest about what it cannot do. It is practical about how to take it and how to know if it is working. And it is realistic about what to do when it does not work, because for about 1 in 3 patients, it does not. Welcome. Chapter 1. Meet Low-Dose Naltrexone. If you have never heard of low-dose naltrexone, you are not alone. Most people have not. Most doctors have not either, or know about it only in passing. That is part of what makes the LDN story unusual. Let me start with the basics. What it is. Naltrexone is a medication that has existed for decades. The Food and Drug Administration approved it in 1984 for opioid use disorder. A few years later, it was also approved for alcohol use disorder. The standard dose for those uses is 50 milligrams a day, taken as a single tablet. At that dose, naltrexone does one main thing. It blocks the receptors in the brain that respond to opioids. If a person on 50 milligrams of naltrexone takes heroin or oxycodone, the drug has nowhere to bind. The high is gone. Over time, the brain learns that opioids no longer produce reward, and the addiction loosens its grip. That is the medical use most pharmacists and doctors know, where LDN comes in. In the 1980s, a New York physician named Bernard Bihari noticed something interesting. When he gave very small doses of naltrexone, around 3 milligrams, to patients with HIV/AIDS, their immune systems seemed to stabilize. The patients lived longer. They got sick less often. He was not curing AIDS, but he was doing something the standard medications were not doing. Bihari kept experimenting. He tried low doses of naltrexone in patients with multiple sclerosis. He tried it in patients with cancer. He tried it in patients with autoimmune disease. He saw responses that did not fit the textbook description of how naltrexone was supposed to work. He had stumbled onto something real. At doses 1/10, the standard level or less, typically between half a milligram and 4.5 milligrams, naltrexone appears to behave like a different medication. It does not just block opioids, it calms inflammation, it steadies the immune system, it quiets parts of the nervous system that have been firing too long. We will explore why in Chapter 3. For now, just know that the low-dose version of this medication does things the standard dose version does not. What it is used for now: LDN is now prescribed off-label for a wide range of conditions. The most common include multiple sclerosis, fibromyalgia and chronic pain, Crohn's disease and other inflammatory bowel diseases, Hashimoto's thyroiditis and other autoimmune diseases, long COVID, mast cell activation syndrome, chronic Lyme disease, mold-related illness, complex regional pain syndrome, depression and anxiety associated with chronic illness. That is a long list and an unusual one. Most medications are designed for one condition. LDN appears to help with many. That fact alone often makes patients suspicious, and it makes some doctors suspicious too. If something sounds too good to be true, it usually is. I understand the suspicion. I shared it once. But the more I worked with LDN and the more research I read, the more I realized that the breadth of LDN's effects is not a sign that the science is shaky. It is a sign that we have stumbled onto a medication that works on a system the body uses for many things at once. The place where the immune system, the nervous system, and the inflammation system meet, calm that system, and many problems improve at the same time. Why low dose matters. This is the part that confuses people most. How can the same medication do different things at different doses? The answer involves something called hormesis, a fancy word for a simple idea. Many things in nature work in opposite directions depending on how much you have. A little stress on a muscle makes it stronger. Too much stress tears it. A little sun is healthy. Too much causes burns. Wine, exercise, fasting all show this pattern. Small amounts produce one effect, large amounts produce another, sometimes opposite effect. Naltrexone follows this pattern. At 50 milligrams, it sits on opioid receptors all day and blocks them. At 4 milligrams, it taps the receptors briefly for 4 to 6 hours and then comes off. That brief tap turns out to do something useful. It signals the body to make more endorphins, the natural feel-good chemicals that help regulate pain, mood, and immune function. By the time the next dose arrives, endorphin levels are higher than they were before. That is part of what LDN does. There is more, and we will get to it. But the basic idea is this: low dose. Naltrexone uses the body's own systems to heal instead of replacing them. A medication with no marketing department. One of the strangest things about LDN is how it has spread. Most medications you have heard of arrived through advertisements, drug reps, or doctors recommending them. LDN arrived through patients. Bernard Bihari published. His patients told other patients. Those patients asked their doctors. A few doctors listened. Those doctors had their own patients try LDN. The patients who improved told their friends. Online support groups formed. International conferences began. The peer-reviewed studies followed slowly but surely. Today, more than 50 published clinical studies support LDN's use in various conditions. The number grows every year. Major academic centers run randomized trials. Insurance companies are starting to take notice, but the heart of LDN spread has always been people, patients sharing experiences with each other and clinicians sharing notes with each other. That is what I mean by a people's medicine. A few practical points before we go deeper. LDN requires a prescription. You cannot buy it over the counter. The standard 50 milligram tablet has to be specially compounded by a pharmacy that can make smaller doses because the doses used for LDN therapy are too small to come in a regular pill. We will talk about how to find a compounding pharmacy in Chapter 11. LDN is inexpensive. A typical month's supply costs between $30 and $60 in the United States, often less. It is not always covered by insurance because it is being used off-label, but the out-of-pocket cost is manageable for most people. LDN is safe. 20 years of clinical use, multiple randomized trials, and millions of doses dispensed have produced no significant safety signals. The most common side effects, vivid dreams, sleep disturbance, mild headache, are usually temporary and mild. Serious side effects are rare. We will cover safety in detail in Chapter 10, that is LDN, in summary, a repurposed medication, an old drug doing new things at low doses, a treatment that spread through patients and clinicians rather than through advertising, a medication that helps about 2/3 of the people who try it. The next chapter explains, in plain terms, why I trust this medication enough to make it a cornerstone of my practice. Chapter 2. 3 reasons I use LDN. When patients ask me why I prescribe LDN so often, I tell them I have 3 reasons. They are simple reasons. None of them are about LDN being a miracle. None of them require you to take my word on faith. They come from 20 years of watching this medication work and not work, and from reading every study I could find. Here they are. Reason 1, it is gentle. Most medications used for the conditions LDN treats come with significant trade-offs. Steroids work fast but cause weight gain, bone loss, and mood changes. Biologics work for some autoimmune diseases but suppress the immune system in ways that increase infection risk. Opioids relieve pain but build tolerance and dependence. Antidepressants help mood but often blunt feeling and sexual function. Sleep medications work but can lead to dependence. LDN is different. At the doses used for therapeutic effect, it does not suppress the immune system. It does not cause weight gain, bone loss, or mood changes. It does not build tolerance. It does not create dependence. It is hard to overdose on. And the side effects, when they happen, are usually mild and temporary. This matters for 2 reasons. First, Gentle medications can be tried early without the patient having to take a leap of faith. If LDN does not work, you stop it, and there is no harm done. Second, gentle medications can be combined with other treatments without dangerous interactions. A patient on LDN can also be on most other medications, with one important exception we will discuss in Chapter 9, opioid pain medications. In medicine, we have a saying, first, do no harm. LDN respects that principle as well as any prescription medication I have used. Reason 2, it works on the system, not the symptom. Most medications target a specific symptom or a specific disease. A migraine medication treats migraines. A blood pressure medication treats blood pressure. A diabetes medication treats blood sugar. This is useful when you have one problem. But many of the patients I see do not have one problem. They have many problems, all at once, all connected. Fatigue and pain and brain fog and joint stiffness and gut trouble and mood changes and poor sleep. When you treat each of these as a separate problem, you end up with 7 medications. Each medication has its own side effects. The side effects interact. The patient feels worse, not better. What if these 7 problems were all branches of the same tree? This is what I have come to believe about many chronic illnesses. Underneath the different symptoms, there is often a common pattern, an immune system stuck in alarm mode, a nervous system that has lost its volume control, and a level of inflammation that the body cannot resolve on its own. Different patients show different symptoms, but the root pattern is similar. LDN appears to work at this root level. It does not target one symptom. It calms the underlying state. When the underlying state calms, many symptoms improve at once. Patients describe it as feeling like the dimmer switch on their illness has finally been turned down. This is also why LDN seems to help so many different conditions: fibromyalgia, long COVID, Hashimoto's, Crohn's disease, MCAS, chronic Lyme, different names, different doctors, different specialty clinics, but underneath a similar pattern of immune and nervous system overactivation. LDN speaks to that pattern. In Chapter 3, I will introduce a phrase I use to describe this: LDN as an immunoadaptogen, a medication that adapts the immune and nervous systems back toward balance, rather than forcing them in one direction. Reason 3, it teaches me something new every year. This may seem like an odd reason for a doctor to give, but it is honest, and it matters. I have prescribed thousands of medications in my career. Most of them are predictable. You give the dose, the patient responds in a known way, you adjust as needed. There is nothing wrong with predictable medications. We need them. LDN is not like that. After 20 years, I am still learning how this medication behaves. I am still seeing patterns I have not seen before. I am still figuring out which patients respond, which do not, and what makes the difference. Every year, new research clarifies a piece of the puzzle. Every year, the patients in my LDN community share observations that change how I prescribe. A medication that keeps teaching its prescriber is rare. It usually means the medication is doing something deeper than we fully understand. That can sound like a weakness. If you do not fully understand it, why do you use it? But I see it as a strength. It tells me LDN is touching parts of human biology that we are only starting to map. It tells me there is more to learn. It keeps me curious. A doctor who has stopped being curious about a medication has stopped paying attention. LDN has not let me stop paying attention. What these 3 reasons mean for you. If you are considering LDN, what these 3 reasons say is this: it is reasonable to try. The medication is gentle. It works on the system rather than chasing symptoms, and it has earned the trust of clinicians who started skeptical and stayed careful. That does not mean LDN will work for you. About 1 in 3 patients does not respond to LDN at standard doses. We will talk about why in Chapter 9 and what to do about it. But the downside of trying LDN, if it does not work, is small. The upside, if it does work, can be significant. I will tell you what I tell my own patients. If you are sick enough to be reading this book, LDN is worth a careful conversation with a knowledgeable doctor. The conversation matters. The medication matters. So does honesty about what it can and cannot do. The next chapter explains, in plain terms, what LDN actually does inside the body, why one medication can help so many different conditions. Chapter 3: How LDN works, endorphins, microglia, and the immunoadaptogen idea. Let me warn you up front. This chapter is the most technical one in the book. I have tried to make it accessible, but the science here is real, and skipping it means missing why LDN does what it does. If you find your eyes glazing over, do this. Read the section headings, look at the simple summaries at the end, and come back later. The rest of the book will make sense without mastering this chapter, but if you can get through it, you will understand LDN at a level most people, including most doctors, never reach. 3 things LDN does. LDN affects the body in at least 3 ways that we know about. There are probably more, but these 3 explain most of what we see clinically. The first is what I call endorphin training. The second is microglia calming. The third is immune steadying. Each of these uses different parts of the body, but they connect. By the end of the chapter, you will see why LDN seems to help so many different conditions. 1. Endorphin training. Endorphins are the body's natural pain relievers and mood lifters. They are made in your brain and released in response to exercise, laughter, music, sex, food, social connection, and other things that make life worth living. The word endorphin is short for endogenous morphine, your body's own morphine. They bind to the same receptors that opioid medications bind to. They are part of why a good run feels good and why a hug from someone you love calms you down. Many people with chronic illness have low endorphin levels. Studies have measured this. Patients with fibromyalgia, chronic fatigue syndrome, depression, and several other conditions consistently show lower endorphin levels than healthy people. Whether this is a cause of the illness or a result of it, no one is fully sure. Probably both, but the pattern is real. Here is what LDN does. When you take a low dose of naltrexone at bedtime, the medication briefly blocks your endorphin receptors. For about 4 to 6 hours, your body thinks it has very few endorphins available. It responds by making more. By morning, the naltrexone has cleared from your system, the endorphin receptors are open again, but now there are more endorphins available than there were yesterday. Over weeks and months of nightly LDN, endorphin levels rise. This is the training part. LDN does not give you endorphins. It teaches your body to make more of them. The metaphor I use with patients is weight training. Lifting a weight tears the muscle slightly. The body responds by building the muscle stronger. LDN puts a brief, gentle stress on the endorphin system. The body responds by building it stronger. Higher endorphin levels mean better mood, less pain, better sleep, and a calmer immune system. This is the first piece of how LDN helps. 2. Microglia calming. This piece is harder to explain because it involves a part of the brain most people have never heard of. Your brain has cells called microglia. They are the brain's immune cells. When everything is well, microglia sit quietly and do housekeeping work, clearing debris, maintaining connections between neurons, supporting the health of brain tissue. But microglia have another mode. When the brain is injured, infected, or stressed, microglia switch into an activated state. In this state, they release inflammatory chemicals to fight off threats. This is useful in the short term. It helps you recover from a head bump or fight off a brain infection. The problem is that microglia, once activated, do not always settle back down. In many chronic illnesses, long COVID, chronic Lyme, mold-related illness, fibromyalgia, chronic fatigue, depression, autism, and others, microglia appear to be stuck in this activated state, even when the original threat is long gone. They keep pumping out inflammatory chemicals. The brain stays inflamed, the patient stays sick. This stuck-on microglia state goes by a name, neuroinflammation. It is one of the most important concepts in modern medicine, and one of the least well-known. Here is where LDN comes in. Microglia have a receptor on their surface called toll-like receptor 4, or TLR44 short. TLR4 is one of the main switches that turns microglia on. When TLR4 is activated, the microglia stay in inflammation mode. LDN blocks TLR4. This is different from how naltrexone blocks opioid receptors. The TLR4 effect happens at very low doses. It is also not a training effect like the endorphin effect. It is a direct calming effect. As long as the LDN is in your system, it sits on TLR4 and tells the microglia, stand down. When microglia stand down, neuroinflammation goes down. When neuroinflammation goes down, the brain symptoms of chronic illness, brain fog, fatigue, mood changes, pain, start to lift. This is the second piece of how LDN helps. 3. Immune steadying. The third piece is the hardest to describe because it involves the immune system, which is itself extraordinarily complex. A simplified picture: your immune system has many different cells, each with a different job. Some cells fight infection, some clean up after fights, some keep the immune response from spinning out of control. In a healthy person, these cells work in balance. Threats are met, threats are cleared, the system stands down. In autoimmune disease, this balance breaks. The immune system starts attacking the body's own tissues. The thyroid in Hashimoto's, the joints in rheumatoid arthritis, the gut lining in Crohn's, the nervous system in multiple sclerosis. The system has lost its ability to tell self from not self, or it has lost its ability to stand down once a fight is over. LDN appears to help restore this balance. It does not suppress the immune system the way steroids or biologics do. Instead, it nudges the immune system back toward equilibrium. Overactive cells calm down. Underactive regulatory cells start working better. The system, over weeks and months, finds its way back to a more balanced state. This is why I call LDN an immunoadaptogen. In traditional medicine, an adaptogen is a substance that helps the body adapt to stress and return to balance, not by forcing one direction or the other, but by supporting the body's own regulation. LDN does this for the immune system. It is gentle. It is two-way. It nudges rather than pushes. Putting it together. Now, picture all three pieces working at once. Endorphin training over months. Microglia calming every night. Immune steadying over weeks. The body's own systems gently brought back toward balance. This is why one medication can help fibromyalgia and Crohn's and long COVID and Hashimoto's and chronic Lyme. It is not that LDN treats each of these diseases separately. It is that all of these diseases share a common underlying state: endorphin depletion, neuroinflammation, and immune imbalance. LDN addresses that shared underlying state. When the underlying state improves, many different conditions improve, because many different conditions share the same roots. The simple summary: if you only remember 3 things from this chapter, remember these. LDN trains your body to make more of its own natural pain relievers and mood lifters. LDN calms the inflammation cells in your brain that get stuck in alarm mode. LDN helps your immune system return to balance instead of fighting itself or its host. That is what LDN does. That is why it helps so many conditions. That is why I call it a people's medicine for chronic illness. In part 2, we turn to the practical question: who does LDN help, and how do you know if it might help you? Chapter 4, conditions where LDN is used. If you are reading this chapter, you probably have one specific question on your mind: will LDN help me? I cannot answer that for you. Even with 20 years of experience, I cannot predict who will respond and who will not. What I can do is walk you through the conditions where LDN is most often used, tell you honestly what the evidence looks like for each, and help you decide whether your situation is a reasonable fit for a trial of this medication. Before we start, 2 things to keep in mind. First, you will see the same pattern over and over in this chapter. Some patients respond beautifully, some respond partially, some do not respond at all. That pattern is not a failure of the science. It is what real medicine looks like. No medication works for everyone. A primer that promises otherwise is not telling you the truth. Second, The conditions in this chapter are not separate islands. Many patients have several at once: fibromyalgia and Hashimoto's and IBS, or chronic pain and depression and poor sleep. LDN often helps with the cluster, not just one piece. As you read, look for the pattern of your own illness, not just the names. Here are the conditions where LDN is most commonly used. Fibromyalgia. This is the condition with the strongest research evidence for LDN. Several randomized trials have shown that LDN reduces pain in fibromyalgia patients. In one well-known study, patients on LDN had a 28.8% reduction in pain. Patients on placebo had an 18% reduction. That gap, about 10%, was statistically significant. That difference may sound modest. In reality, for a patient who has lived with fibromyalgia pain for years and been told there is nothing more to do, a 10% reduction can feel like getting a piece of life back. Many of my fibromyalgia patients describe it that way. Fibromyalgia tends to fall in the Category 1 response group from Chapter 9. Patients for whom LDN alone may be enough. About 2/3 of fibromyalgia patients respond meaningfully. A small percentage have dramatic responses. About a third do not respond at all, and we will talk about what to do for them later in the book. Chronic pain, and LDN as a novel anti-inflammatory medication. The case for LDN in chronic pain is stronger than many people realize, and a single researcher has done more than anyone else to establish it. Dr. Jared Younger, a pain researcher now at the University of Alabama at Birmingham, has spent more than 15 years studying LDN in chronic pain conditions. His foundational paper, published in Clinical Rheumatology in 2014, made the case that LDN should be understood as a novel anti-inflammatory medication, not just a repurposed addiction drug, and not just a curiosity for fibromyalgia. That framing matters. Most anti-inflammatory medications work by suppressing the immune system or by blocking specific inflammatory chemicals. LDN works differently. It calms the activated microglia in the brain and spinal cord, the cells we discussed in Chapter 3, and lets the nervous system come out of its inflammatory state on its own. This is a mechanism that no other medication on the market shares. What does this mean clinically? It means LDN has a specific role to play in the kinds of pain that involve neuroinflammation. These include neuropathic pain, pain caused by damaged or irritated nerves, often described as burning, electric, shooting, or stabbing; complex regional pain syndrome, CRPS, a severe, often disabling pain condition that develops after an injury or surgery; trigeminal neuralgia, sudden, severe facial pain caused by nerve irritation; postherpetic neuralgia, the persistent nerve pain that can follow shingles; diabetic neuropathy, nerve damage from long-term diabetes; central sensitization syndromes, conditions where the nervous system has become hypersensitive to pain signals, including fibromyalgia, chronic widespread pain, and many post-injury chronic pain conditions. For these conditions, LDN's effects can be dramatic when they work. CRPS is one of the most notable examples. CRPS is a condition in which the nervous system goes into a state of permanent alarm after an injury, producing pain far out of proportion to what is reasonable. Standard pain medications often fail. Several published case series have shown patients with long-standing CRPS achieving substantial pain reduction on LDN, sometimes dramatically. A 2013 case series from the University of California showed that 2 CRPS patients had near complete resolution of their pain on LDN after years of unsuccessful treatment with other approaches. More cases have been reported since. A retrospective analysis from the Mayo Clinic found that 65% of patients taking LDN for chronic pain reported some benefit. A 2021 systematic review in Pain Physician concluded that LDN appears effective across multiple chronic pain conditions. A 2025 retrospective cohort study published in the Journal of Pain Research, looking at real-world outcomes in a single pain physician's practice, found similar response rates and confirmed that the medication is well tolerated even in complex pain patients. For chronic pain that is not primarily neuroinflammatory, say mechanical back pain from a herniated disc or arthritis pain from joint damage, LDN's role is smaller. It may still help, particularly if there is an inflammatory component, but it is not the primary tool. For neuroinflammatory pain, however, LDN is one of the most reliable medications I have used in 20 years of practice. Two practical points worth knowing. First, neuropathic pain sometimes does not respond to standard LDN doses. Some patients with stubborn nerve pain need significantly higher doses, sometimes 10 milligrams, 25 milligrams, or even higher, to get a response. We will discuss this in Chapter 9. Second, LDN works alongside most other pain treatments. It is not an either/or with physical therapy, nerve blocks, or other medications. It can be added to an existing pain plan without disrupting what is already working. If you have neuropathic pain, CRPS, or another neuroinflammatory pain condition, LDN deserves a serious conversation with a knowledgeable clinician. The evidence is real, the mechanism is established, and the response rate when the patient is appropriate is among the highest of any LDN application. Multiple sclerosis, MS. LDN has been used in MS since Bernard Bihari's early work in the 1980s. Several small studies have shown improvements in quality of life, fatigue, and spasticity in MS patients on LDN. The medication does not appear to slow disease progression in the way disease-modifying therapies can. But for patients already on disease-modifying therapy, LDN can provide additional symptom relief, particularly fatigue and pain, without interfering with the primary treatment. Most MS specialists are not familiar with LDN. If you have MS and want to try LDN, you may need to bring this option to your neurologist, rather than wait for your neurologist to bring it to you. Crohn's disease and ulcerative colitis. The evidence for LDN in Crohn's disease is among the strongest in the field. A randomized, placebo-controlled trial published in 2011 showed significant improvements in disease activity and mucosal healing, meaning the gut lining actually looked better on colonoscopy after LDN treatment. Pediatric studies have shown similar benefits in children with Crohn's. The medication is gentle enough to be a reasonable option for patients who cannot tolerate biologics or who want to try something less aggressive first. Ulcerative colitis evidence is weaker but suggestive. Many of my IBD patients use LDN as an adjunct to other treatment, and some use it as their primary medication once their disease is in remission. Hashimoto's thyroiditis and other autoimmune thyroid conditions. This is the condition that started my LDN journey, and it remains one of the conditions where I most often see patients respond. LDN does not replace thyroid hormone replacement. If your thyroid has been damaged by the autoimmune process and you need levothyroxine, you will probably keep needing it. But LDN can calm the underlying autoimmune attack on the thyroid. Patients often see their thyroid antibodies drop over months. They feel less of the fatigue, brain, fog, and joint pain that often persist even when thyroid hormone levels look perfect on labs. If your thyroid hormone levels look normal, but you still feel terrible, autoimmune inflammation may be part of the picture. LDN is worth a conversation. Other autoimmune diseases. LDN has been used in a wide range of autoimmune conditions beyond Hashimoto's thyroiditis. The evidence base for any single condition is smaller than for fibromyalgia or Crohn's, but the principle is the same. LDN calms the immune dysregulation that drives autoimmune disease, and many patients respond. The autoimmune conditions where LDN has been used with at least some published evidence or reported clinical experience include multiple sclerosis, discussed earlier in this chapter, rheumatoid arthritis, case series and clinical reports of reduced joint pain, stiffness, and inflammatory markers, lupus, systemic lupus erythematosus, reduced fatigue, joint pain, and disease activity in case series, Sjogren's syndrome, improvements in dry eyes, dry mouth, fatigue, and joint pain, scleroderma, systemic sclerosis, limited evidence, but reports of improved skin and digestive symptoms, psoriasis and psoriatic arthritis, case reports of skin clearance and reduced joint inflammation, ankylosing spondylitis, reduced morning stiffness and pain, ulcerative colitis, covered earlier alongside Crohn's. Some patients respond well. Celiac disease and non-celiac gluten sensitivity, sometimes used for the broader autoimmune and inflammatory pattern. Type 1 diabetes, limited evidence, sometimes, used for associated autoimmune conditions in the same patient, Behçet's disease. Case reports of improved symptoms, sarcoidosis. Case reports of improvement in patients with inflammatory and pain symptoms. Antiphospholipid syndrome, limited evidence, sometimes used as adjunct. Vitiligo, case reports of pigmentation return in some patients. Alopecia areata, frontal fibrosing alopecia, and lichen planopilaris, emerging evidence in autoimmune hair loss conditions. Endometriosis, increasingly recognized as having an inflammatory and immune component. Covered later in this chapter, pernicious anemia, autoimmune hepatitis, autoimmune pancreatitis, case-level reports. This is not an exhaustive list, and inclusion does not mean LDN is a primary treatment for any of these conditions. For severe autoimmune disease that requires immune-suppressing medications, biologics, methotrexate, cyclophosphamide, or others, LDN does not replace those treatments. It can sit alongside them, often allowing for better symptom control, or in some cases, lower doses of the heavier medications. This kind of combined approach requires careful coordination with your specialist. The pattern across these conditions is consistent. About 2/3 of patients see meaningful improvement on LDN. The improvements are often gradual, taking months rather than weeks. Some patients see their inflammatory markers, such as antibody levels in Hashimoto's or disease activity scores in lupus and rheumatoid arthritis, trend downward over time. Others see no change in lab markers but feel better: less fatigue, less joint pain, less brain fog, better sleep. The mechanism is the same as in any autoimmune condition. Calmer immune system, lower neuroinflammation, higher endorphin tone, different conditions, same root pattern, same response. If you have an autoimmune condition not on the list above, do not assume LDN cannot help. The list reflects what has been published or reported, not the limits of where LDN may be useful. Many of the autoimmune diseases now well documented as LDN responsive started as case reports from individual clinicians who tried it on a hunch and saw results. The science continues to follow the practice. Depression and anxiety associated with chronic illness. LDN is not a first-line antidepressant. If you have depression that is not connected to a chronic physical illness, other treatments, therapy, conventional antidepressants, lifestyle medicine should come first. But for patients whose depression and anxiety arose alongside chronic illness, LDN can help. The endorphin effect lifts mood. The neuroinflammation effect calms the brain fog and dread that often come with chronic illness. Many patients tell me their mood improved before their physical symptoms did. The mind in chronic illness often heals first. Sleep disturbance and insomnia in chronic illness. Many of my patients have terrible sleep, not the kind of insomnia that resolves with sleep hygiene, but the wired and tired insomnia of an immune system that will not stand down. LDN at bedtime can help here. Some patients see improvement in the first week, others take a few weeks. A small minority experience the opposite: vivid dreams or sleep disturbance, and need to switch to morning dosing. We will cover this in Chapter 10. Itchy skin conditions and dermatologic problems. Hailey-Hailey disease, a rare blistering skin condition, has well-documented responses to LDN. Several case series have shown patients moving into long-term remission on LDN after years of failed treatments. Other dermatologic conditions, including some forms of psoriasis, lichen planus, and chronic urticaria, have also been reported to respond. If you have a stubborn skin condition that has not responded to standard treatment, LDN is worth asking your dermatologist about. Endometriosis and pelvic pain. Several small studies and clinical experience suggest LDN can help with endometriosis-associated pain and pelvic pain syndromes. The evidence is preliminary, but consistent enough that LDN is increasingly used by gynecologists familiar with chronic pelvic pain. A list is not a promise. Everything I have just listed has at least some evidence and clinical experience behind it. None of it is a guarantee that LDN will work for your version of the condition. The honest summary for any of these conditions is the same. Roughly 2 out of 3 people respond. Roughly 1 out of 3 do not. We cannot tell ahead of time which group you are in. The cost of trying LDN, financially, in terms of side effects, in terms of risk, is small compared to most other treatments for chronic illness. The cost of not trying, if you would have responded, is missing months or years of better function. That is the calculation I lay out for my patients. It is a reasonable calculation for most of the conditions in this chapter. The next 3 chapters take a closer look at 4 condition clusters that come up most often in my practice, and where the evidence and the clinical strategy deserve their own discussion. They are the post-infectious neuroimmune syndromes, long COVID, mold, Lyme, and MCAS, cancer, and the pediatric population. Chapter 5. Long COVID, mold, Lyme, and MCAS. These 4 conditions share a strange and sad family resemblance. Patients arrive in my office having been told by doctor after doctor that nothing is wrong with them. Their lab tests look normal, their imaging looks normal, their physical exams are unremarkable, and yet they are profoundly sick. They are tired all the time. Their cognition has slipped, their bodies hurt, their moods are unstable. They cannot exercise without crashing for days. Many have had to stop working, stop driving, or stop caring for their own children. Some have been ill for years. Many have been told it is in their head. It is not in their head. The science is catching up. What ties these 4 conditions together, long COVID, mold-related illness, chronic Lyme disease, and mast cell activation syndrome, MCAS, is the same underlying pattern. An infection or environmental exposure triggered an immune response. The trigger came and went, but the immune system never stood down. It stayed activated, stayed inflamed, stayed looking for fights even when there was nothing left to fight. The body's regulatory systems lost their ability to bring the alarm down. In other words, the underlying state I described in Chapter 3, endorphin depletion, neuroinflammation, immune imbalance, is dialed up to its loudest in these patients. This is exactly the state LDN was made for. Not because LDN cures these conditions, it does not, but because LDN can lower the volume of the underlying alarm enough that the body has a chance to start healing. Let me take each condition in turn. Long COVID, also called post-acute sequelae of COVID-19, or PASC, refers to the constellation of symptoms that persist for weeks, months, or years after a COVID-19 infection. Common symptoms include fatigue, brain fog, post-exertional malaise, a worsening of symptoms after physical or mental activity, headaches, joint and muscle pain, autonomic dysfunction, often diagnosed as POTS, sleep disturbance, and mood changes. LDN has emerged as one of the more promising treatments for long COVID. A study published in 2023 from Stanford University, working with patients in their PASC clinic, found that LDN was associated with a meaningful reduction in the number of symptoms, improved fatigue, better sleep, and improved functional status. A 2025 study from Australia showed that LDN restored function in a specific type of immune cell that is consistently abnormal in long COVID patients. Multiple other studies, large and small, have reported similar findings. In my own practice, long COVID is now one of the most common reasons patients seek out LDN. Response rates appear similar to other chronic conditions. About 2/3 of patients see meaningful benefit, 1/3 do not. For those who respond, the improvement is often dramatic enough that patients describe it as feeling like they got their lives back. Long COVID often requires LDN as one part of a larger treatment plan. Many patients also benefit from pacing strategies, learning not to push through fatigue, nutritional support, treatment of POTS or mast cell symptoms when present, and rehabilitation that respects post-exertional malaise. LDN sets the stage. Other treatments build on that foundation. Mold-related illness and chronic inflammatory response syndrome, CIRS. Mold-related illness is real, controversial, and difficult to treat. Some patients are genetically predisposed to react badly to mold toxins, mycotoxins, released by mold growing in water-damaged buildings. When these patients are exposed for long enough, their immune systems get stuck in a state of chronic inflammation. The exposure triggers a cascade of immune, hormonal, and inflammatory changes that do not resolve when the patient leaves the building. This pattern has a name in some circles: chronic inflammatory response syndrome, or CIRS. Many conventional doctors do not recognize CIRS. Many integrative doctors do. The science is real, even though the clinical recognition lags. LDN does not treat the mold itself. The first step in any mold case is removing the patient from the toxic environment, leaving the moldy building, replacing affected belongings, sometimes detoxifying. But once the exposure is removed, LDN can help calm the inflammatory pattern that often persists. Patients on LDN often report that brain fog lifts, energy returns, and sensitivity to other triggers, foods, chemicals, smells, decreases over months. If mold is part of your story, LDN belongs in your treatment plan, but it is not the whole plan. You will need a clinician who understands mold illness, a small but growing group. Chronic Lyme disease and post-treatment Lyme disease syndrome. Lyme disease is an infection caused by the bacterium Borrelia burgdorferi, transmitted by tick bites. When caught early and treated with antibiotics, most cases resolve, but a significant minority of patients, somewhere between 10 and 20%, continue to have symptoms long after antibiotic treatment is complete. These patients are sometimes told they have post-treatment Lyme disease syndrome. Others believe they have chronic Lyme disease, an active, ongoing infection. The medical world remains divided about whether the persistent symptoms reflect ongoing infection or a post-infection inflammatory state. The honest answer is probably both, depending on the patient. Some patients have evidence of ongoing infection. Others have cleared the infection but continue to suffer from the inflammatory aftermath. LDN does not treat Lyme infection. If active infection is present, antibiotics or other antimicrobial treatment is necessary. But for the inflammatory aftermath, the fatigue, brain fog, joint pain, mood changes, and post-exertional malaise that persist after treatment, LDN can be very helpful. Many patients with persistent Lyme symptoms find LDN to be one of the more useful tools in their long recovery. Chronic Lyme is typically a Category 2 situation from our framework. LDN is necessary but not sufficient. Most patients also need attention to co-infections, Bartonella, Babesia, others, gut health, mold exposure, mitochondrial support, and slow rehabilitation. Mast cell activation syndrome, MCAS. Mast cells are immune cells that live in tissues throughout the body. They normally release chemicals like histamine when they detect a real threat, an allergen, an infection, an injury. In MCAS, the mast cells become unstable. They release their chemicals at small or imagined provocations or for no clear reason at all. The result is a confusing array of symptoms that can include flushing, itching, hives, gut trouble, brain fog, fatigue, racing heart, low blood pressure, and food and chemical sensitivities. MCAS often co-occurs with POTS, postural orthostatic tachycardia syndrome, and with hypermobile Ehlers-Danlos syndrome, a connective tissue disorder. The three together form a pattern many of us see in clinic: hypermobile patients with autonomic dysfunction and unstable mast cells. LDN can help MCAS in two ways. The TLR4 effect calms one of the receptors that triggers mast cell activation. The general anti-inflammatory effect helps the broader inflammatory pattern that often accompanies MCAS, but LDN alone is rarely enough for MCAS. Most patients also benefit from mast cell stabilizers, particularly ketotifen and cromolyn sodium. We will cover the MCAS combination protocol in Chapter 9. MCAS is the clearest example I have of a condition where LDN works best as part of a stack. Why this chapter cluster matters. Patients with these four conditions are often the most desperate patients I see. They have been dismissed, dismissed again, and dismissed once more. They have spent thousands of dollars on doctors who could not help them. Some have been told their illness is anxiety, depression, or simply the result of getting older. Many have started to doubt themselves. If you are one of these patients, please hear me. Your illness is real. The science is catching up. There are tools that can help. LDN is one of them. It is not a cure. It is not magic. About a third of you will not respond, and we have other strategies for that. But for the two-thirds who do respond, LDN is often the first treatment in years that offered real relief. Chapter 6, LDN and Cancer, an honest look. This chapter requires more care than any other in the book. Cancer is the disease where false hope is most cruel. It is also the disease where patients are most desperate for hope of any kind. As a doctor, I take the responsibility of writing about cancer treatment seriously. I want you to leave this chapter with an accurate picture, not a sales pitch and not a dismissal. Here is the honest truth about LDN and cancer. LDN is not a cancer cure. I'm going to repeat that because it matters. LDN is not a cancer cure. There is no medication, supplement, or alternative treatment that reliably cures cancer on its own. Anyone who tells you otherwise is either misinformed or trying to sell you something. Cancer treatment in 2026 is built around surgery, radiation, chemotherapy, immunotherapy, and targeted therapies. These conventional treatments have transformed cancer from a uniformly fatal disease into a disease many people survive, sometimes for decades. If you have been diagnosed with cancer, your first conversation should always be with an oncologist trained in conventional cancer care. That said, there is a real and growing body of evidence that LDN may have a role to play alongside conventional cancer treatment. The role is supportive. The mechanism is real. The clinical reports are interesting, and in the right hands, LDN can be a useful addition to a thoughtful, integrative cancer care plan. Let me explain. The science of LDN and cancer. Two laboratories, working independently, have produced the bulk of the basic science. Dr. Ian Zagan and his colleagues at Penn State have spent decades studying what they call the opioid growth factor pathway, a system in the body that regulates cell growth and division through opioid receptors. Their work has shown that LDN can slow the growth of certain cancer cells in laboratory and animal studies. Their hypothesis is that LDN's brief transient blockade of opioid receptors triggers an upregulation that interferes with cancer cell proliferation. Dr. Y. Liu in London and Dr. Angus Dalgleish at St. George's University of London have published similar work. Their studies suggest that LDN at low doses produces gene expression changes in cancer cells that are not seen at standard doses, implying that LDN's anti-cancer effect is fundamentally different from naltrexone's effect at addiction treatment doses. These are basic science findings. They are real. They are also a long way from proof that LDN works in human cancer patients. The clinical evidence. The most well-known clinical work comes from Dr. Burton Berkson, a physician in New Mexico, who has published several case reports and case series describing remarkable outcomes in patients with advanced cancer treated with a protocol combining intravenous alpha lipoic acid with LDN. His most cited cases include long-term survivors of metastatic pancreatic cancer, B-cell lymphoma, and metastatic renal cell carcinoma, all conditions where conventional medicine offered limited hope. These case reports are interesting. They are not, however, randomized controlled trials. They are individual patient stories. Some critics have argued that the cases represent unusual responders to conventional treatment, or that the patients had additional therapies that contributed to their outcomes. Others argue the cases are real evidence of meaningful biological effect. Without proper trials, we cannot know. What we can say is this: the Berkson cases are real patients with real outcomes. The basic science from the Zagon and Liu laboratories supports the plausibility of an anti-cancer effect. The risk of LDN itself is very low, the cost is minimal, and LDN can be safely combined with most conventional cancer treatments without interference. How LDN might help in cancer care. I see 4 reasonable roles for LDN in cancer care, and I want to be specific about each. First, as supportive care during conventional treatment. Patients undergoing chemotherapy, radiation, or surgery often suffer from fatigue, pain, mood disturbance, sleep disruption, and immune dysfunction. LDN can help with all of these. It does not interfere with conventional cancer treatment. It does not blunt the effect of immunotherapy. In fact, some early evidence suggests LDN may enhance the effects of certain immunotherapies, though more research is needed. Second, after conventional treatment, as part of a recovery and prevention plan, patients who have completed conventional cancer treatment often want to do everything they can to reduce the risk of recurrence. LDN, with its anti-inflammatory and immune balancing effects, can be one part of this. It is not the whole plan. Diet, exercise, stress management, sleep, and addressing underlying inflammation matter at least as much. Third, in patients with advanced cancer who want to combine conventional and integrative approaches. For some patients with advanced cancer, conventional treatment options are limited. These patients often pursue integrative approaches, working with practitioners who combine evidence-based supplements, dietary strategies, and medications like LDN with whatever conventional care remains available. This is the population the Berkson cases come from. Some patients in this group have remarkable outcomes. Many do not. The honest answer is that we cannot promise any specific result. Fourth, in patients who decline conventional cancer treatment, some patients, for personal reasons, choose not to pursue conventional cancer care. I do not endorse that choice in most cases. Conventional treatment saves lives that would otherwise be lost. But if a patient has made that decision after thorough discussion with an oncologist and they want to pursue integrative approaches alone, LDN is among the more reasonable options. It will not cure their cancer. It may help with quality of life. It may, in some cases, slow disease progression. The evidence here is even thinner than the supportive care evidence. What I tell my own cancer patients: when a patient with cancer asks me about LDN, I tell them several things. I tell them their oncologist comes first. Whatever else we do, conventional cancer care is the foundation. I have referred many patients back to oncologists who could help them. I have never told a patient with treatable cancer to refuse treatment. I tell them LDN is reasonable to add. The downside is small. The potential upside in supportive care alone is meaningful. The cost is manageable. I tell them I cannot promise results. I have seen patients with advanced cancer do remarkably well on integrative protocols, including LDN. I have also seen patients with the same diagnoses progress and die despite our best efforts. Cancer is humbling. I tell them not to spend their savings on alternative cancer treatments that promise cures. Real integrative. Cancer care is built around supporting the patient through conventional treatment, not replacing it. If you have cancer and you are reading this chapter, I hope it has given you a clear picture. LDN is worth considering. It is not enough on its own. Find an oncologist you trust. Find an integrative physician who works with cancer patients. Build your team, do the work, and bring whatever hope you can carry alongside whatever realism you can muster. That is the most honest answer I know how to give. Chapter 7, LDN for Children. LDN can be used in children, but it requires a careful approach and a knowledgeable prescriber. The pediatric world is a different world. Children are not small adults. Their bodies, their dosing, their disease patterns, and their long-term considerations all differ from adults. Conditions where LDN is used in children. The most established pediatric use of LDN is in children with Crohn's disease. A 2013 pilot study showed that LDN was safe and tolerable in children with moderate to severe Crohn's. Many of the children in the study experienced improvement in disease activity. Pediatric gastroenterologists in some centers now use LDN as one option among several, particularly for children whose disease is not severe enough to require biologics or whose families want to try a gentler approach first. LDN has also been used in children for autism spectrum disorder, particularly in children who have associated symptoms like irritability, self-injurious behavior, or significant inflammation. The early studies of naltrexone in autism in the 1990s used higher doses than current LDN protocols. The results were mixed, and naltrexone is not a mainstream treatment for autism today. Some integrative pediatric clinicians use LDN at low doses as one component of a broader treatment plan for some children with autism. The evidence is preliminary. If your child has autism and you are considering LDN, work with a clinician who has experience in this specific application. LDN has been used in children with juvenile fibromyalgia, complex regional pain syndrome, CRPS, and chronic pain syndromes. The evidence here is mostly case reports and case series. A pediatric pain clinic experience published in 2023 reported that 59 children received LDN for chronic pain, with meaningful response in many. Pediatric pain medicine remains an underserved field, and LDN is one of the few options that combines reasonable evidence with a strong safety profile. Other reported uses in children include Hashimoto's thyroiditis, chronic Lyme disease, post-infection syndromes including pediatric long COVID, and intractable epilepsy in specific contexts. These uses are not standard. They require an experienced clinician and careful monitoring. Dosing in children. Pediatric LDN dosing is generally weight-based. A common starting point is roughly 0.1 milligrams per kilogram per day, which means a child weighing 20 kilograms, about 44 pounds, would start somewhere around 2 milligrams per day. Some clinicians start much lower, 0.5 milligrams or even microgram doses, and titrate up slowly. For children, dose form matters. Liquid LDN, prepared by a compounding pharmacy, is often easier to use than capsules because it allows precise dosing as the child grows. Some compounding pharmacies prepare liquid LDN in concentrations that allow for dosing changes by drop count. Special considerations. Children's bodies handle naltrexone differently than adults. Younger children clear the drug somewhat faster. The standard adult duration of action, about 4 to 6 hours, may be slightly shorter in young children. This is one reason pediatric dosing requires adjustment. Children with developmental conditions or sensory sensitivities may be more reactive to side effects. Vivid dreams or sleep disruption that an adult might tolerate can be more disruptive for a child. Starting low and titrating slowly is even more important in this population than in adults. Long-term safety data in children is more limited than in adults. The data we have are reassuring. There are no signals of harm in the studies completed to date, but a child who starts LDN at age 10 may be on it for many years. We are still learning the long-term picture. Working with your pediatrician. Most pediatricians have not heard of LDN. This is not a reflection on the quality of your pediatrician. It is a reflection on how slowly emerging treatments penetrate pediatric specialty training. If you want to try LDN for your child, your best path is usually through an integrative pediatric clinician, a pediatric specialist, gastroenterologist for IBD, neurologist for chronic pain, etc., who has worked with LDN, or in some cases, an integrative adult clinician who is comfortable with pediatric dosing. You can ask your existing pediatrician to oversee monitoring even if they are not the prescriber. A note to parents. If you are a parent of a chronically ill child and you are considering LDN, I want to acknowledge how hard your situation is. Watching your child suffer from an illness that conventional medicine has only partial answers for is one of the most painful experiences a parent can have. The temptation to try anything that might help is strong and understandable. LDN is a reasonable thing to try for many pediatric conditions where the evidence base supports it. It is gentle. It is well tolerated. The downside risk is low, but it is also not a miracle, and it should not be the only thing you try. A child with chronic illness usually needs a team, a primary clinician, the right specialists, attention to nutrition, school support, mental health support, and family resilience. LDN can fit into that team. It cannot replace it. If you are the parent making this decision, trust your instincts, gather the team, and take the journey one step at a time. There are more children doing well on LDN than most parents realize. Your child may be one of them. Chapter 8: Finding the Right Dose. If there is one thing I want you to take away from this entire book, it is this. The right dose of LDN is the dose that works for you. That sounds obvious, it is not. For most of LDN's history, the medication has been prescribed at a single dose, 4.5 milligrams at bedtime, as if that number were settled science. It is not. It was a starting point used by Dr. Bernard Bihari in his early work, and it became the default by habit rather than by evidence. 20 years of clinical experience and a growing body of research have made one thing clear. The optimal dose of LDN varies enormously from person to person. Some patients do best on 0.5 milligrams. Others do best on 4.5 milligrams. Some need 6 milligrams or higher. A small group does best on doses so small they have to be specially prepared, measured in micrograms or even nanograms. If your dose is not right, LDN will not work the way it could. This chapter is about how to find the dose that fits you, the standard starting approach. For most adults starting LDN, the conventional approach goes like this. Start at 1.5 milligrams at bedtime and increase to 3 milligrams after 1 to 2 weeks. Then increase to 4.5 milligrams after another 1 to 2 weeks. That is the protocol most LDN prescribing doctors have used for decades. For about half of patients, this works. They reach 4.5 milligrams, settle in, feel better over the following weeks, and stay on that dose long term. For the other half, the standard approach causes problems. Some patients feel worse on 4.5 milligrams than they did on 3 milligrams. Some reach 4.5 milligrams and feel nothing at all. Some never tolerate the climb past 1.5 milligrams. Some need to keep going past 4.5 milligrams to find their sweet spot. This is the most common mistake I see in LDN prescribing. Patients are titrated to 4.5 milligrams, told that is the dose, and left there even when their body is telling them something different. If you do not feel better at 4.5 milligrams, the answer is rarely LDN does not work for you. The answer is more often, this is not your dose. The hormetic curve. In Chapter 1, I mentioned a concept called hormesis, the principle that the same substance can have opposite effects at different doses. LDN follows this pattern. Imagine a curve. On the left, at very low doses, LDN does nothing. There is not enough medication to produce an effect. As the dose climbs, the curve rises. Benefits begin. They increase. Eventually, the curve reaches a peak, the patient's sweet spot. If the dose climbs further, the curve falls. Too much LDN starts to produce the opposite of what we want. Inflammation may return. Side effects may worsen. The benefits fade. Every patient has their own curve. The shape of the curve, the location of the peak, the steepness of the rise, all of these vary from person to person. The job of LDN dosing is to find your peak. Listening to your body. The signals your body sends as you titrate are the most important data you have. More than lab numbers, more than a doctor's protocol, more than what worked for your friend on LDN. Your body will tell you what is working. Here is what I tell patients to watch for as they increase their dose. Energy. Is your energy improving, staying the same, or getting worse? Improvement means you are climbing toward your sweet spot. Worsening means you may have gone past it. Sleep. Is your sleep deeper and more restorative? Or is it disrupted by vivid dreams, waking, or insomnia? Some sleep disturbance is normal in the first weeks. Persistent sleep problems may mean the dose is too high or the timing is wrong. Pain. If you started LDN for pain, is the pain decreasing? Slowly is normal. No change after a month at a particular dose may mean the dose is not enough. Worsening pain may mean you have gone too far. Mood. Is your mood lifting, steady, or sinking? Most patients notice a slight mood lift on the right dose. A mood drop or new anxiety may signal the dose is wrong for you. Brain fog. Is mental clarity returning? This often takes longer than mood or sleep, but it is a key signal. Patients on the right dose often describe their thinking as sharper, less effortful, more themselves. Inflammation symptoms, joint pain, stiffness, swelling, GI symptoms. Are they trending in the right direction? If most of these signals are pointing the right way, you are on the right path. If they are pointing the wrong way, the dose probably needs adjustment. The endorphin reserve question. Some patients cannot tolerate the standard starting dose at all. They feel terrible at 1.5 milligrams, wired, sleepless, agitated, more pain, more fatigue. The instinct of an inexperienced prescriber is to push through. The right answer is almost always the opposite. Drop the dose and start lower. Why? Because some patients have severely depleted endorphin reserves. Their bodies have been running on empty for so long that even a brief blockade of endorphin receptors is too much for the system to handle. These patients do not need the standard adult starting dose. They need a much lower starting dose. The clinical assessment is straightforward. The questions I ask my patients before I prescribe LDN are simple. How long have you been sick? Years of chronic illness deplete endorphin reserves more than months. How is your sleep? Deep restorative sleep replenishes endorphins. Years of poor sleep depletes them. How is your energy? Patients with severe fatigue, especially patients who can no longer work or exercise, often have very low reserves. How resilient are you? Do small setbacks crash you for days? Do you bounce back from stress, or does every challenge derail you for a week? Low resilience suggests low reserves. What is your functional capacity? Can you cook a meal, do a load of laundry, run an errand? Or are you spending most of your day in bed? Severely limited function often means severely limited reserves. If you scored low on most of these, you are likely a candidate for ultra-low dose starting strategies. If you scored higher, the standard approach probably fits. The microgram and nanogram approach. For sensitive patients, doses much lower than the standard 1.5 milligrams can be the right starting point. The LDN Research Trust now recognizes 3 categories: low dose, 1 to 4.5 milligrams, sometimes up to 10 milligrams; very low dose, 0.01 to 0.5 milligrams; ultra, low dose, 1 to 2 micrograms. A microgram is 1,000th of a milligram. At 1 microgram, the medication is binding to opioid receptors, but in such small amounts that it is barely producing the standard endorphin training effect. Some clinicians believe ultra-low doses work through a different mechanism entirely, possibly acting as a weak agonist, something that activates receptors rather than blocks them, through hormesis. For some highly sensitive patients, even microgram doses are too much. There is a small but growing experience with nanogram dosing, 1,000th of a microgram, or 1/1,000,000th of a milligram. These doses are not commonly available from compounding pharmacies. Some clinicians prepare them through serial dilution. The clinical evidence at this dose range is limited, but for a small group of patients, this is the only dose they can tolerate, and they do report benefit. If you are starting LDN and you have severe chronic illness, low functional capacity, or a history of being highly reactive to medications, Ask your prescriber whether starting in the very low or ultra low range makes sense for you. Many LDN knowledgeable clinicians will agree. Titration speed. Standard titration moves to 4.5 milligrams within 2 to 4 weeks. For sensitive patients, this is far too fast. I tell my sensitive patients to expect a slower journey. Some of my patients increase their dose every 2 weeks. Others go 4 weeks between increases. The most sensitive patients need 3 months between increases, sometimes longer. This is not slow because we are being cautious for caution's sake. It is slow because the body needs time to adapt. A patient who has been chronically ill for a decade is not going to recover in 3 weeks. The endorphin system rebuilds gradually. Pushing the dose faster than the body can adapt creates side effects without speeding the benefit. The patients who do best on LDN, in my experience, are the patients who gave the medication time. The patients who do worst are often the ones who pushed too fast. When to stop titrating? You have found your dose when the benefits have plateaued. You went up by 1 notch and felt better. You went up by another notch and felt about the same. That is your sweet spot. Stay there. If the next increase makes you feel worse, more pain, more fatigue, more side effects, drop back to the previous dose. That was your sweet spot. The curve has turned downward. Most patients reach their sweet spot somewhere between 1.5 and 4.5 milligrams. A meaningful minority reach it lower. A meaningful minority reach it higher. None of these are wrong. The right dose is the dose that works for you. Timing. The other variable in LDN dosing is when you take it. Most prescribers default to bedtime because there is some evidence that nighttime dosing aligns with the body's natural endorphin release patterns and may produce a stronger training effect. But not everyone tolerates bedtime dosing. For some patients, LDN at bedtime causes vivid dreams, sleep disturbance, or insomnia. These patients usually do better taking LDN in the morning. Some patients split their dose, taking half in the morning and half in the evening. There is no single right answer on timing. If bedtime works for you, stay with bedtime. If bedtime disrupts your sleep, switch to morning. Try both if needed. The medication still works. A summary table. I find a simple table helpful for patients who are figuring out their dose. Here is the framework I use. Standard adult, moderate illness. Start at 1.5 milligrams at bedtime. Titrate to 3 milligrams, then 4.5 milligrams over 2 to 4 weeks. Settle at the dose that produces the best response. Sensitive adult, significant illness. Start at 0.5 milligrams or lower. Titrate every 2 to 4 weeks. Most patients land between 1.5 and 4.5 milligrams. Very sensitive adult, severe illness. Start at microgram doses, 1 to 2 micrograms. Titrate slowly, with intervals of 1 to 3 months between dose changes. Some patients stay at microgram doses long term. Very ill, low functional capacity, microgram or nanogram dosing, long titration intervals. Patience is essential. Children. Weight-based dosing starting at roughly 0.1 milligrams per kilogram per day. Liquid formulation often easier than capsules. Side effects at low doses. Drop to a lower dose. Slow the titration. The dose that produces side effects is by definition past your sweet spot. Non-response in neuropathy or CRPS. Consider higher doses, 10 to 25 milligrams, sometimes higher. Discuss with a knowledgeable clinician, covered in Chapter 9. The most important thing this table can teach you is that there is no one number. There is only your number. Find it and stay with it. Chapter 9. When standard LDN doesn't work. About 1 out of every 3 patients who tries LDN does not respond at standard doses. This is the honest truth of LDN therapy, and it is the part of the LDN story that is most often glossed over. If you are one of these patients, do not assume LDN cannot help you. There are several strategies for non-responders, and many patients who failed at standard doses have found success with a different approach. This chapter walks through what to do when LDN at 4.5 milligrams is not working. First, confirm you have given it a fair trial. Before deciding LDN is not working, make sure you have actually given it a fair trial. Three things have to be true. You have to be on the right dose. If you titrated to 4.5 milligrams quickly and stopped there, you may have skipped your actual sweet spot. Try dropping to 3 milligrams or even 1.5 milligrams and stay there for several weeks. Some patients do best at lower doses than the conventional protocol suggests. You have to have given it enough time. Some LDN benefits arrive in weeks, many take months. The endorphin training effect builds gradually. The neuroinflammation calming effect builds gradually. Patients who quit at 6 weeks because nothing dramatic has happened sometimes turn out to be the ones who would have responded beautifully at month 4. If you are stable on a dose, give it at least 8 to 12 weeks before deciding it is not working. You have to be on a reliable formulation. LDN has to be compounded, and not all compounding pharmacies are equal. Some compounding pharmacies prepare LDN poorly with inconsistent dosing or unstable preparations. If you are not responding, consider whether the medication itself might be the issue. Some patients have switched compounding pharmacies and started responding immediately. If you have given LDN a fair trial, right dose, enough time, reliable formulation, and you are still not responding, then it is time to consider the strategies in this chapter. Strategy 1. Try higher doses, especially for nerve pain. The conventional 4.5 milligram ceiling is not a real ceiling. It is a starting point that has stuck around longer than the evidence supports. For some patients, especially patients with neuropathic pain or CRPS, doses higher than 4.5 milligrams are necessary to get a response. Some patients need 6 milligrams, some need 10 milligrams, some need 25 milligrams or higher. This is sometimes called moderate dose naltrexone to distinguish it from the standard low-dose protocol. It may work through different mechanisms than the lower dose effects we discussed in Chapter 3. The endorphin training effect probably weakens or disappears at these higher doses, but other effects, anti-inflammatory action, modulation of glial cells in the spinal cord, direct opioid receptor effects, may become more important. Higher doses are not for everyone. They require careful titration and a knowledgeable clinician. They are most appropriate for patients with neuropathic pain who have failed to respond at standard doses, patients with CRPS who have failed at standard doses, patients with severe central sensitization who have failed at standard doses. If you are in one of these categories and standard LDN has not worked, ask your clinician whether a careful trial at higher doses is reasonable. The risk profile remains favorable. The medication is still inexpensive, and for some patients, this is the dose range where their response finally appears. Strategy 2. Add ketosis. A ketogenic diet, or in some cases exogenous ketones, can dramatically improve LDN response in some patients. The combination of LDN and ketosis is increasingly used in chronic neuroinflammatory conditions, and the rationale is solid. Ketones are an alternative fuel source for the brain. When the body is in a state of ketosis, either through diet or through supplementation, the brain runs on ketones instead of glucose. Ketones produce less inflammation in brain cells than glucose does, particularly in cells that are already stressed or inflamed. The combination of LDN's microglia calming effects and ketosis's anti-inflammatory metabolism can be greater than either alone. The most reliable way to achieve ketosis is through diet, a true ketogenic diet with very low carbohydrate intake, under 30 grams per day, and adequate fat. This is hard to maintain. It requires real commitment, ideally with the help of a clinician or nutritionist familiar with therapeutic ketogenic diets. Exogenous ketones, supplements that raise ketone levels without dietary changes, are easier but less reliable. Some patients benefit, others do not. They are reasonable to try if dietary ketosis is not feasible for you. Ketosis is particularly worth considering for refractory neuropathic pain, long COVID with significant brain fog and fatigue, ME/CFS and chronic fatigue syndromes, MCAS with significant neurological symptoms, treatment-resistant depression with inflammatory features. Strategy 3. Add mast cell stabilizers, especially for MCAS. For patients with mast cell activation syndrome, MCAS, LDN alone is often not enough. The combination of LDN with mast cell stabilizers is one of the most useful drug stacks in chronic illness medicine. The two most useful mast cell stabilizers are ketotifen and cromolyn sodium. Ketotifen is an oral medication that stabilizes mast cells, preventing them from releasing histamine and other inflammatory chemicals. It is taken at bedtime usually, starting at 1 milligram and titrating up to 2 to 4 milligrams over several weeks. Side effects are usually mild, some sedation, occasional weight gain, occasional dry mouth. Ketotifen is not approved by the FDA in the United States as an oral medication, but it is available through compounding pharmacies and is widely used internationally. Cromolyn sodium is another mast cell stabilizer, available as an oral solution or as a nasal spray. It works similarly to ketotifen, but with a different mechanism. It is often used in combination with ketotifen for severe MCAS. Cromolyn is generally well tolerated and has been used for decades, originally for asthma and allergic conditions. The MCAS combination protocol I use most often goes like this. LDN at the patient's optimal dose, usually 0.5 to 4.5 milligrams. Ketotifen 1 to 4 milligrams at bedtime. Cromolyn sodium oral solution before meals, with the dose adjusted based on response. Some patients also benefit from adding H1 and H2 antihistamines, like loratadine and famotidine, to this combination. The protocol has to be tailored to the individual. For MCAS patients who have not responded to LDN alone, adding mast cell stabilizers is often the missing piece. Strategy 4. Add methylene blue and mitochondrial support. Methylene blue is an old medication with new applications. It was first synthesized in the 1870s, used as a textile dye, and later used in medicine for treating malaria, methemoglobinemia, and several other conditions. What has put methylene blue back in the spotlight is its effect on mitochondria. Mitochondria are the energy factories of every cell in your body. In chronic illness, mitochondria often function poorly. Patients feel exhausted because their cells, at the most basic level, cannot produce enough energy. Methylene blue acts as an alternative electron carrier in the mitochondrial electron transport chain. In plain language, it helps mitochondria produce energy more efficiently. It also has anti-inflammatory effects in the brain, reduces oxidative stress, and may improve cognitive function. For patients with chronic fatigue, brain fog, MCAS with neurological symptoms, or other conditions where mitochondrial dysfunction is part of the picture, methylene blue combined with LDN can be powerful. The combination is especially useful when paired with ketosis. Methylene blue, ketosis, and LDN together address brain inflammation from 3 different angles at once. Methylene blue requires care. It interacts with many medications, especially serotonergic medications, most antidepressants, certain pain medications, and some others. Combining methylene blue with these medications can cause serotonin syndrome, a potentially serious condition. Anyone considering methylene blue should work with a clinician who understands these interactions. The dose used for chronic illness applications is much lower than the dose used in hospital medicine, usually 5 to 25 milligrams per day, sometimes higher in specific cases. It is taken in the morning. The pharmaceutical-grade version, suitable for human use, is essential. The version sold for fish tanks is not safe for human consumption. Strategy 5. Address the underlying drivers. Sometimes LDN does not work because LDN cannot work, because the underlying driver of the illness is not addressed. If you have undiagnosed mold exposure, LDN cannot help until you address the mold. If you have active Lyme co-infections, LDN cannot help until they are treated. If your gut is severely dysbiotic, LDN cannot help until the gut starts healing. If you have severe nutrient deficiencies, LDN cannot help until they are corrected. If you have chronic stress that you cannot reduce, LDN cannot work in a body that is constantly being re-inflamed. This is the part of LDN non-response that is hardest to talk about because it does not have a simple medication answer. The honest truth is that some patients have not responded to LDN because the LDN was working as well as it could on a body that was being constantly re-injured by something else. If you are not responding to LDN despite a fair trial, ask yourself and your clinician whether something else is driving the illness. Common drivers worth considering include mold exposure, often missed, Lyme and tick-borne co-infections, hidden infections, Epstein-Barr virus reactivation, Helicobacter pylori, others. Heavy metal exposure, severe nutrient deficiencies, especially B12, vitamin D, magnesium, iron, hormonal imbalances, especially thyroid and adrenal, untreated sleep apnea, ongoing trauma, or chronic high-stress life circumstances. A patient who is on LDN, who is also addressing whichever of these drivers applies to them, often does much better than a patient who is on LDN alone. Strategy 6. The Comprehensive Functional Medicine Workup. For patients who have failed multiple LDN strategies, a deeper investigation may be needed. This often means working with a functional medicine clinician who can run a broader set of tests and consider a wider range of possibilities than conventional medicine usually does. A comprehensive workup might include detailed gut testing, stool analysis for dysbiosis, parasites, inflammation markers, testing for mold mycotoxins and indoor environment assessment, Lyme and co-infection testing through specialized labs, heavy metal testing, nutrient and mineral panels, hormone testing, thyroid, adrenal, sex hormones, genetic testing for relevant variations, MTHFR, COMT, others, inflammatory marker panels, detailed sleep evaluation. Not every patient needs every test. A good clinician will choose the tests that fit your story. The point is not to test everything, but to look for the underlying drivers that may be keeping you sick. The big picture. If LDN at standard doses is not working for you, you have options. Higher doses for nerve pain, ketosis for neuroinflammation, mast cell stabilizers for MCAS, methylene blue and mitochondrial support for fatigue, investigation of underlying drivers when nothing else works. About 1 in 3 patients does not respond to standard LDN. Of that group, a meaningful number respond to one of the strategies in this chapter. Some patients work through multiple strategies before they find what works. The principle that should guide all of this is the principle I introduced in Chapter 2. One dragon at a time. Do not change everything at once. Add one strategy, give it time, see if it helps, then consider whether you need to add another. Patients who change everything at the same time rarely figure out what is helping and what is not. If you have failed at standard LDN, do not give up on the medication and do not give up on yourself. Find a clinician who knows the territory. Try the next strategy. Be patient. The journey is longer for some patients than for others. The destination is still reachable for most. Chapter 10. Side effects and how to manage them. LDN has one of the most favorable side effect profiles of any prescription medication used for chronic illness. That is one of its greatest strengths, but favorable does not mean none. About 10 to 20% of patients experience some side effect during the first weeks on LDN. Most of these are mild and temporary. A small number are persistent enough that patients need to adjust their approach. This chapter walks through what to expect, what is normal, and what to do if you run into trouble. The most common side effects. The side effects you are most likely to hear about in rough order of frequency are vivid dreams. This is the most common LDN side effect, and depending on the patient, it can be charming, neutral, or disruptive. The dreams are often unusually vivid, story-like, and emotionally rich. Some patients enjoy them, others find them disturbing or sleep disrupting. Sleep disturbance. This includes trouble falling asleep, waking during the night, or feeling unrefreshed in the morning. It often goes together with vivid dreams. Most cases resolve within a few weeks, Persistent sleep disruption is a signal to adjust dose or timing. Headaches. Mild to moderate headaches occur in some patients during the first 1 to 2 weeks. They usually resolve as the body adapts. Nausea or stomach upset. Some patients have mild GI symptoms in the first days. These usually pass within a week. Persistent nausea may mean the dose is too high. Fatigue or feeling worse before feeling better. Some patients feel slightly worse in the first 1 to 2 weeks before they feel better. This is sometimes called the initial flare and is most common in patients with significant inflammation or immune activation. Anxiety or restlessness. Some patients experience increased anxiety, particularly at higher doses or with bedtime dosing. This is usually a signal that the dose is too high, the timing is wrong, or both. Mood changes. The most common mood change is a mild lift, but some patients experience low mood, irritability, or emotional lability, especially in the first weeks. Dose-related side effects at higher doses. Pushing past the patient's sweet spot can cause loss of effectiveness, return of symptoms, headache, and a general sense of being unwell. Side effects you should know about but rarely happen. Allergic reactions are uncommon but possible. Some patients react to fillers used in compounded LDN rather than to naltrexone itself. Switching to a different compounding pharmacy or a different formulation often solves the problem. Liver enzyme elevations have been reported at standard naltrexone doses, 50 milligrams, but are exceedingly rare at LDN doses. Routine liver monitoring is not generally needed for patients on LDN, though clinicians sometimes check baseline liver enzymes before starting. Withdrawal does not occur with LDN because the medication is too short-acting and the doses are too low to produce dependence. Patients can stop LDN at any time without a taper. Interactions with other medications are uncommon, with one major exception we will discuss: the opioid interaction. Important to understand. This is the only LDN interaction that requires careful attention. LDN blocks opioid receptors. If you take opioid pain medications, oxycodone, hydrocodone, morphine, fentanyl, tramadol, codeine, others, LDN can interfere with their effect. This usually means the opioid will not work as well as it should. In some cases, taking an opioid while on LDN can cause precipitated withdrawal, sudden, severe withdrawal symptoms even if you are not opioid dependent. There is also a less discussed but important risk. After a patient has been on LDN for some time, their opioid receptors become sensitized. If LDN is then stopped or its effect wears off, about 4 to 6 hours after the dose, the patient may be unusually sensitive to opioids. A normal dose of an opioid pain medication can produce stronger effects than expected, including respiratory depression in extreme cases. The practical implications: if you are on chronic opioid pain medication, LDN is generally not appropriate. You would have to stop the opioid for a period before starting LDN. This is a major decision and requires careful work with your clinician. If you might need short-term opioids for surgery, dental work, or acute injury, hold your LDN. Stop LDN at least 24 hours before, and resume after the opioid is no longer needed. Tell your surgeon or dentist that you are on LDN. If you have to take an opioid unexpectedly, hold LDN until you no longer need the opioid. Resume LDN once the acute situation is resolved. Wear a medical alert bracelet or carry a card noting LDN use, particularly if you have any condition that might require emergency opioid pain treatment. This is the one interaction that LDN prescribing doctors take very seriously. Most other medications are fine to combine with LDN. Managing the most common side effects. Vivid dreams. If the dreams are pleasant or neutral, no action is needed. If they are disturbing, your options are: switch dosing to morning instead of bedtime, lower the dose, or both. Most patients who switch to morning dosing lose the vivid dreams but keep the therapeutic benefits. Sleep disturbance. Same options as vivid dreams. Try morning dosing first. If sleep is still disrupted on morning dosing, consider whether the dose is too high. Headaches. Most resolve in 1 to 2 weeks. If they persist, lower the dose. Adequate hydration, magnesium supplementation, and sometimes a brief pause in dosing before restarting at a lower level can help. Nausea. Take LDN with food. Lower the dose if needed. Most cases resolve with these steps. Initial flare. Often the right answer is patience. The flare usually settles within 1 to 2 weeks. If it does not, drop the dose. Some patients need to start at very low or ultra low doses to avoid the flare entirely. Anxiety or restlessness. Almost always a sign the dose is too high. Drop to the previous tolerated dose and stay there longer before titrating up. The push-through question. Some patients are told that side effects mean LDN is working and they should push through. Some online communities promote this idea. Many older protocols assumed it. I disagree strongly. If you are having side effects, your body is telling you something. The dose is too high for where you are right now, or the timing is wrong, or both. Push through is not a strategy. It is a way to make patients miserable. The right approach when side effects appear is the opposite. Drop back. Drop to the previous tolerated dose. Stay there for several weeks. If you eventually want to titrate up again, do it more slowly than before. Many patients who failed LDN had simply been pushed too fast. Side effects are signals, not obstacles. Listen to them. Adjust the dose. Honor your body's pace. The patients who do best on LDN are not the ones who pushed through. They are the ones who paid attention. A final word on safety. LDN has been used clinically for more than 35 years. Hundreds of thousands of patients have taken it. Multiple randomized trials have studied it. The medication has no significant safety signals. No one has died from LDN. No long-term harms have emerged. That is an extraordinary safety record. Few medications used for chronic illness can match it. If you are considering LDN and worried about safety, you can be reassured. The downside risk is small. The most likely problems, vivid dreams, mild sleep disturbance, occasional headache, are inconveniences, not dangers. The main thing that requires real attention is the opioid interaction, and that is manageable with planning. For most patients, the most important question is not, is LDN safe? It is, will LDN work? The safety question is largely answered. The effectiveness question is the one we work through, patient by patient, dose by dose. The next chapter turns to the practical question of how to actually obtain LDN, finding a prescriber, finding a pharmacy, and talking to a doctor who may never have heard of this medication. Chapter 10: Side Effects and How to Manage Them. LDN has one of the most favorable side effect profiles of any prescription medication used for chronic illness. That is one of its greatest strengths, but favorable does not mean none. About 10 to 20% of patients experience some side effect during the first weeks on LDN. Most of these are mild and temporary. A small number are persistent enough that patients need to adjust their approach. This chapter walks through what to expect, what is normal, and what to do if you run into trouble. The most common side effects. The side effects you are most likely to hear about, in rough order of frequency, are vivid dreams. This is the most common LDN side effect, and depending on the patient, it can be charming, neutral, or disruptive. The dreams are often unusually vivid, story-like, and emotionally rich. Some patients enjoy them, others find them disturbing or sleep disrupting. Sleep disturbance. This includes trouble falling asleep, waking during the night, or feeling unrefreshed in the morning. It often goes together with vivid dreams. Most cases resolve within a few weeks. Persistent sleep disruption is a signal to adjust dose or timing. Headaches. Mild to moderate headaches occur in some patients during the first 1 to 2 weeks. They usually resolve as the body adapts. Nausea or stomach upset. Some patients have mild GI symptoms in the first days. These usually pass within a week. Persistent nausea may mean the dose is too high. Fatigue or feeling worse before feeling better. Some patients feel slightly worse in the first 1 to 2 weeks before they feel better. This is sometimes called the initial flare and is most common in patients with significant inflammation or immune activation. Anxiety or restlessness. Some patients experience increased anxiety, particularly at higher doses or with bedtime dosing. This is usually a signal that the dose is too high, the timing is wrong, or both. Mood changes. The most common mood change is a mild lift, but some patients experience low mood, irritability, or emotional lability, especially in the first weeks. Dose-related side effects at higher doses. Pushing past the patient's sweet spot can cause loss of effectiveness, return of symptoms, headache, and a general sense of being unwell. Side effects you should know about but rarely happen. Allergic reactions are uncommon but possible. Some patients react to fillers used in compounded LDN rather than to naltrexone itself. Switching to a different compounding pharmacy or a different formulation often solves the problem. Liver enzyme elevations have been reported at standard naltrexone doses, 50 milligrams, but are exceedingly rare at LDN doses. Routine liver monitoring is not generally needed for patients on LDN, though clinicians sometimes check baseline liver enzymes before starting. Withdrawal does not occur with LDN because the medication is too short-acting and the doses are too low to produce dependence. Patients can stop LDN at any time without a taper. Interactions with other medications are uncommon, with one major exception we will discuss: the opioid interaction. Important to understand. This is the only LDN interaction that requires careful attention. LDN blocks opioid receptors. If you take opioid pain medications, oxycodone, hydrocodone, morphine, fentanyl, tramadol, codeine, others, LDN can interfere with their effect. This usually means the opioid will not work as well as it should. In some cases, taking an opioid while on LDN can cause precipitated withdrawal. Sudden, severe withdrawal symptoms even if you are not opioid dependent. There is also a less discussed but important risk. After a patient has been on LDN for some time, their opioid receptors become sensitized. If LDN is then stopped or its effect wears off about 4 to 6 hours after the dose, the patient may be unusually sensitive to opioids. A normal dose of an opioid pain medication can produce stronger effects than expected, including respiratory depression in extreme cases. The practical implications. If you are on chronic opioid pain medication, LDN is generally not appropriate. You would have to stop the opioid for a period before starting LDN. This is a major decision and requires careful work with your clinician. If you might need short-term opioids for surgery, dental work, or acute injury, hold your LDN. Stop LDN at least 24 hours before and resume after the opioid is no longer needed. Tell your surgeon or dentist that you are on LDN. If you have to take an opioid unexpectedly, hold LDN until you no longer need the opioid. Resume LDN once the acute situation is resolved. Wear a medical alert bracelet or carry a card noting LDN use, particularly if you have any condition that might require emergency opioid pain treatment. This is the one interaction that LDN prescribing doctors take very seriously. Most other medications are fine to combine with LDN. Managing the most common side effects. Vivid dreams. If the dreams are pleasant or neutral, no action is needed. If they are disturbing, your options are switch dosing to morning instead of bedtime, lower the dose, or both. Most patients who switch to morning dosing lose the vivid dreams but keep the therapeutic benefits. Sleep disturbance. Same options as vivid dreams. Try morning dosing first. If sleep is still disrupted on morning dosing, consider whether the dose is too high. Headaches. Most resolve in 1 to 2 weeks. If they persist, lower the dose. Adequate hydration, magnesium supplementation, and sometimes a brief pause in dosing before restarting at a lower level can help. Nausea. Take LDN with food. Lower the dose if needed. Most cases resolve with these steps. Initial flare. Often the right answer is patience. The flare usually settles within 1 to 2 weeks. If it does not, drop the dose. Some patients need to start at very low or ultra-low doses to avoid the flare entirely. Anxiety or restlessness. Almost always a sign the dose is too high. Drop to the previous tolerated dose and stay there longer before titrating up. The push-through question. Some patients are told that side effects mean LDN is working and they should push through. Some online communities promote this idea. Many older protocols assumed it. I disagree strongly. If you are having side effects, your body is telling you something. The dose is too high for where you are right now, or the timing is wrong, or both. Push through is not a strategy. It is a way to make patients miserable. The right approach when side effects appear is the opposite. Drop back. Drop to the previous tolerated dose. Stay there for several weeks. If you eventually want to titrate up again, do it more slowly than before. Many patients who failed LDN had simply been pushed too fast. Side effects are signals, not obstacles. Listen to them. Adjust the dose. Honor your body's pace. The patients who do best on LDN are not the ones who pushed through. They are the ones who paid attention. A final word on safety. LDN has been used clinically for more than 35 years. Hundreds of thousands of patients have taken it. Multiple randomized trials have studied it. The medication has no significant safety signals. No one has died from LDN. No long-term harms have emerged. That is an extraordinary safety record. Few medications used for chronic illness can match it. If you are considering LDN and worried about safety, you can be reassured. The downside risk is small. The most likely problems, vivid dreams, mild sleep disturbance, occasional headache, are inconveniences, not dangers. The main thing that requires real attention is the opioid interaction, and that is manageable with planning. For most patients, the most important question is not is LDN safe, it is will LDN work? The safety question is largely answered. The effectiveness question is the one we work through patient by patient, dose by dose. The next chapter turns to the practical question of how to actually obtain LDN. Finding a prescriber, finding a pharmacy, and talking to a doctor who may never have heard of this medication. Chapter 11. Finding a prescriber and talking to your doctor. The hardest part of starting LDN is often not the medication itself. It is finding a doctor willing to prescribe it. Most physicians have not heard of LDN. Many of those who have heard of it have heard only enough to be skeptical, a low dose of an addiction medication, used off-label for autoimmune conditions. With most evidence in journals, their specialty does not read. They will not say no out of malice. They will say no because they do not know enough to say yes. This chapter is about how to navigate that reality. The 2 best ways to find a prescriber. 20 years of watching patients find LDN knowledgeable clinicians has taught me that 2 paths work better than any others. The first and best path is to join an LDN support group and ask. The patient communities are where the practical knowledge lives. Members in your state, your city, sometimes your zip code, will know which doctors prescribe LDN and which ones do not. They will know who is good and who is brisk. They will know who takes new patients and who is full. They will know who accepts insurance and who is cash only. There are several active LDN communities, and joining one is free. The LDN support group on Facebook, the largest of the patient communities, with members worldwide and active state-by-state recommendations. The LDN support group on School, a parallel community offering structured learning and deeper engagement, LDNsupportgroup.org, consolidated educational and community resources. Post a question. Tell the group what state you live in and what condition you are trying to treat. You will usually get useful recommendations within hours. The community has helped tens of thousands of patients find prescribers this way. It will help you too. The second path is to call compounding pharmacies near you and ask. LDN has to be specially compounded. The standard 50 milligram tablet from a regular pharmacy cannot produce a 1.5 or 4.5 milligram dose. Every patient on LDN gets it from a compounding pharmacy. The pharmacists at those pharmacies know which doctors in their area write LDN prescriptions because they fill the prescriptions every day. Search for compounding pharmacy near your address. Call the pharmacy directly. Ask, do you compound low-dose naltrexone, and do you know which prescribers in this area write LDN prescriptions? Most compounding pharmacists will be happy to share names. They have no reason not to. The doctors are not their competitors. They are their referral sources. Between these 2 paths, patient communities, and compounding pharmacies, most people find a prescriber within a week or two. Other paths worth considering. If neither of the two main paths gives you what you need, here are additional options. The LDN Research Trust maintains a directory of LDN knowledgeable clinicians on their website. The list is not comprehensive, but it is curated. Many of the physicians listed have spoken at LDN Research Trust conferences or have been recommended by trusted clinicians in the field. Integrative and functional medicine practices are more likely to prescribe LDN than conventional practices. The Institute for Functional Medicine maintains a clinician directory. Many integrative medicine fellowship graduates are familiar with LDN. Telemedicine clinics specializing in LDN have grown significantly since the COVID-19 pandemic. Several practices now offer LDN consultations across multiple states by virtual visit. This option works particularly well for patients in rural areas or in states with few LDN prescribers. Some practices specialize in specific conditions, long COVID, MCAS, chronic Lyme, and may be a good fit if your case is complex. Your existing specialist may surprise you. Some rheumatologists, neurologists, gastroenterologists, and pain specialists prescribe LDN, even though they do not advertise it. If you have a specialist you trust, ask. The worst answer is no, but here is someone who does. What to do if your existing doctor will not prescribe LDN. This is the situation many patients find themselves in. They have a primary care physician they like, who is open-minded but unfamiliar with LDN. They want to ask about LDN without burning bridges. They want to give their doctor a fair chance to consider the request. The best approach is a written request, supported by published references. A brief, respectful letter is much more effective than trying to summarize LDN verbally during a 15-minute appointment. Your doctor can read the letter on their own time, look at the references, and come back to you with a thoughtful response. Here is a sample letter you can adapt to your situation. Fill in the blanks, attach the references, and bring it to your next appointment or send it through your patient portal. Date blank. Dear Doctor, my name is Entolko and my date of birth is Ventanpoko. I am writing to ask whether you would consider prescribing low-dose naltrexone LDN for my condition. There is growing evidence supporting LDN as a novel immune modulator and neuromodulator, and it has an excellent safety profile. I have included selected references below for your review. Thank you for considering this request. Sincerely, the St. Price. Selected references on low-dose naltrexone. 1. Tolyan K. and Vrooman, B. 2018. Low-dose naltrexone LDN. Review of therapeutic utilization. Medical Sciences, Basel, 6/4/82. https://doi.org/10.3390/medsci 604000822. Lee, Z, U, Y, Griffin, N, Fung, J, and Shan, F. 2018. Low-dose naltrexone LDN. A promising treatment in immune-related diseases and cancer therapy. International Immunopharmacology, 61, 178-184. https://doi.org/1016/j.intimp.2018.05.020. 3. Kant, R., Dalgleish, A.G., and Allen, R.L., 2017. Naltrexone inhibits IL-6 and TNF-alpha production in human immune cell subsets following stimulation with ligands for intracellular toll-like receptors. Frontiers in Immunology, 8/809. https://doi.org/10.3389/FIMMU.2017.0080994. Younger, J., Parkitney, L., and McLean, D., 2014. The use of low-dose naltrexone, LDN, as a novel anti-inflammatory treatment for chronic pain. Clinical Rheumatology, 33/4/4. 451 to 459. https://doi.org/10.1007/S1007-2 5. Patton, DK, Schultz, BG, and Berlau, DJ, 2018. The safety and efficacy of low-dose naltrexone in the management of chronic pain and inflammation in multiple sclerosis, fibromyalgia, Crohn's disease, and other chronic pain disorders. Pharmacotherapy, 38, 382 to 389. https://doi.org/10.1002/phar.20866. Lundin, AP, Steidl, K, Kamalian, L, et al. 2023. Low-dose naltrexone in inflammatory bowel disease, a systematic review and meta-analysis. Crohn's and colitis 365-2, OTAD 020, https://doi.org/1093/CRO/OTAD 020. 7. Chopra, P. and Cooper, M.S. 2013. Treatment of complex regional pain syndrome, CRPS, using low-dose naltrexone, LDN. Journal of Neuroimmune Pharmacology, 8-3, 470 to 476, https://doi.org/10.1007/S110481-013-9451-Y. These 7 references are well chosen. They cover the broad therapeutic literature, Toljan and Vrooman, Lee et al., the mechanism, Kant et al. On inflammation, Younger et al. As the foundational anti-inflammatory paper, the major condition reviews, Patton et al., Lundin et al., and a striking specific application, Chopra and Cooper, on CRPS. Together, they demonstrate that LDN is supported by peer-reviewed evidence in major journals, not fringe publications. What to expect when your doctor reads the letter? Doctors respond to written requests in 3 general ways. Some say yes, they read the references, recognize the evidence, and write the prescription. This is more common than you might expect, especially with primary care physicians who are open to off-label medications. And some say, let me think about it. They want time to read more, to talk to a colleague, or to consider whether they are comfortable. Give them that time. Follow up in 2 weeks. Many doctors who initially hesitate end up prescribing. Some say no. They may have specific concerns. They may not be comfortable with off-label prescribing. They may simply not have time to learn about a new medication. None of these are wrong. A doctor who is not comfortable prescribing a medication they do not know is a careful doctor, not a bad one. If your doctor says no, do not argue. Thank them for considering the request. Then return to the 2 best paths, the support group and the compounding pharmacy, to find another prescriber. You can keep your existing doctor for everything else and find a separate clinician for LDN. Many patients work with this kind of split team successfully. A few practical considerations. Insurance. LDN is rarely covered by insurance because it is being used off-label. The good news is that LDN is inexpensive. A typical month's supply costs between $30 and $60 in the United States, sometimes less. Most patients pay out of pocket without significant hardship. Some compounding pharmacies offer better cash prices than others. It is worth shopping. Frequency of follow-up. Most LDN prescribers want to see patients more often during the first 3 months. Typically, one follow-up around 6 weeks and another around 3 months, then less often once the dose is settled. After the first year, many patients see their LDN prescriber once a year for refills. Coordination with other doctors. Tell all of your doctors that you are taking LDN. The opioid interaction discussed in Chapter 10 is the main concern. Surgeons, dentists, emergency room physicians, and pain specialists need to know. Wear a medical alert bracelet or carry a card. Prescribers in different states. If you live in a state with few LDN prescribers, telemedicine practices can fill the gap. Most LDN telemedicine clinicians are licensed in multiple states. Make sure the clinician is licensed in your state, that the compounding pharmacy can ship to you, and that your state allows the telemedicine relationship for your particular condition. The bottom line: finding an LDN prescriber takes effort, but it is not as hard as it once was. The patient communities have made it dramatically easier. The compounding pharmacies are reliable second-tier referral sources. The integrative medicine community has grown. Telemedicine has filled gaps that geography used to create. If you want to try LDN, you can find a way. It may take a week or a month. It will not take a year. Once you have your prescriber, your pharmacy, and your first prescription in hand, the next chapter walks you through what to expect during the first 90 days, when LDN tends to start working, what is normal and what to do when something seems off. Chapter 12: What to expect in the first 90 days. The first 90 days on LDN are the most important. They will tell you whether the medication is going to help you. They will also be the period when you are most likely to have questions, doubts, and the occasional bump in the road. This chapter walks through the typical timeline. Your experience may differ. Some patients respond faster than the timeline suggests. Some respond slower. A few do not respond at all. But the rhythm I am about to describe is what most LDN patients encounter, and knowing the pattern in advance makes the journey easier. Week 1. Starting LDN. Your first dose of LDN is anticlimactic. Most patients feel nothing on the first day or the second or the third. This is normal. LDN is not a fast-acting medication. It is more like a vitamin than a painkiller. It works gradually, building effect over weeks and months. What you may notice in the first week: vivid dreams. Often, but not always. Most patients tolerate them. Some find them strange. Others find them interesting. A few find them disruptive. If they are disturbing, talk to your prescriber about switching to morning dosing. Mild sleep changes. Sleep may be lighter, or you may wake during the night, or you may sleep more deeply than usual. Almost all of these settle within a week or two. Subtle mood shifts. Some patients describe feeling slightly calmer or slightly more alert within the first few days. Others notice nothing. No change in main symptoms: pain, fatigue, brain fog. Most of these will not budge in the first week. Do not expect them to. If you have significant side effects in the first week, strong anxiety, severe sleep disruption, bad headaches, an increase in your underlying symptoms, talk to your prescriber. The dose may need to be lower, or the timing may need to change. Weeks 2 to 4, titrating up. If the standard protocol works for you, this is the period when you increase your dose from 1.5 milligrams to 3 milligrams, from 3 milligrams to 4.5 milligrams. Some prescribers move faster, some slower. At each new dose level, you may experience another brief round of vivid dreams or mild sleep changes. This usually settles within a few days at the new dose. The first real signs that LDN may be working often appear in this window. Patients commonly notice, in this order, better sleep depth. Not necessarily more sleep, but more restorative sleep. Waking feeling like you actually rested. Slightly improved mood or mental clarity. A subtle lift, often described as feeling more like myself. Modest reduction in inflammatory symptoms. Less morning stiffness. Less joint pain. Less digestive disruption. Each of these is usually small at first. If you are not noticing any of these changes by week 4, do not panic. Many patients do not notice changes until later. But if side effects are worsening rather than settling, slow down. Weeks 4 to 8, the response window opens. This is the period when most responders begin to notice meaningful change. The endorphin training effect has had time to build. The microglia calming effect has been working night after night. The immune system has had several weeks to settle toward better balance. What patients commonly report in this window: noticeable reduction in pain. For fibromyalgia and chronic pain patients, this is often the first big signal. Pain that was a 7 out of 10 may be a 5. The improvement may not feel dramatic, but it is real. Better energy. Not normal energy, but better than baseline. Patients often describe being able to do one more thing in the day than they could before. Clearer thinking, brain fog lifting in patches, words coming more easily, conversations feeling less effortful, better stress tolerance. setbacks not crashing you for as many days, recovery from minor stress happening faster. For patients with autoimmune conditions, the changes in this window are often subtler. Inflammatory markers may not have shifted yet. The improvements may be felt in fatigue and joint pain rather than in lab numbers. Be patient, the deeper changes take longer, weeks 8 to 12, assessing whether it is working. By this point, you have been on LDN for around 3 months, with most of that time at your settled dose. This is when you and your prescriber should make a real assessment. The questions to ask yourself: is my main symptom improving? If you started LDN for pain, is the pain less? If you started for fatigue, is your energy better? If you started for autoimmune disease, do you feel less of the systemic burden of that disease? Is my function better? Can you do more in a day than you could 3 months ago? Is your stress tolerance better? Is your sleep more restorative? Are my lab numbers moving? For autoimmune conditions, antibodies may be starting to trend down. For chronic pain conditions, markers of inflammation may be improving. These changes are slow, but the direction matters. Are side effects manageable? Mild side effects are normal. Disruptive side effects mean the dose is wrong. If the answers are mostly yes, congratulations. You are responding to LDN. Stay on your current dose for several more months and let the effects deepen. Many patients see their best results after 6 to 12 months, not at the 3-month mark. If the answers are mostly no, do not give up. Talk to your prescriber. The strategies in Chapter 9, different doses, ketosis, mast cell stabilizers, methylene blue, investigating underlying drivers are the next steps. What to track. You will get more out of this 90-day window if you keep simple notes. You do not need a complicated system. A small notebook or a notes app on your phone is enough. Once a week, jot down current LDN dose and timing, average pain level 1 to 10, average energy level 1 to 10, mood low, neutral, lifted, any new symptoms, any side effects, one sentence about how the week felt overall. Sleep quality: poor, fair, good, very good. The patterns are easy to miss in real time. Looking back across 8 or 12 weeks of notes, the trend is usually clear. Patients are often surprised. Wait, my pain was a 7 every day in week 1, and now I am writing 5. Most days that the change was happening even though they had not noticed. This kind of tracking also helps your prescriber. When you arrive at your 3-month follow-up, you have data. The conversation is more productive than trying to remember how you felt 8 weeks ago. Common patterns of response. Patients tend to fall into a few common patterns during the first 90 days. Knowing the pattern in advance can save you worry. The steady responder. Modest gains every 2 to 4 weeks, building over months. No drama, no setbacks. By month 6, the patient is meaningfully better. About half of LDN responders fit this pattern. The slow burner. Almost no change for the first 2 to 3 months, then improvement begins around month 3 or 4. These patients often nearly quit at the 8-week mark. The ones who stay on the medication are usually glad they did. About a quarter of responders fit this pattern. The bumpy responder: 2 steps forward, 1 step back, a good week, then a flare, better sleep, then a stretch of poor sleep. Eventually the trend is upward, but the journey is not smooth. This pattern is most common in patients with complex multisystem illness. About a fifth of responders fit this pattern. The early surprise. A small group of patients respond dramatically in the first 2 to 4 weeks. Pain falls, energy returns, sleep transforms. These responses can feel almost too good to be true. They are rare, but real. These patients often have a specific kind of inflammatory illness that LDN addresses very directly. The non-responder: 3 months on standard LDN, no meaningful change in main symptoms, no clear trend in tracking notes. About a third of patients fit this pattern. The next step is the strategies in Chapter 9. Do not interpret 3 months of no response as proof that nothing will help. Many of these patients find their answer in the strategies that come next. When to call your prescriber before the 3-month mark. Most of the time, you should give LDN time and not bother your prescriber with every minor question. But some situations warrant an earlier call, severe or persistent side effects that do not settle within a week or two, new symptoms that concern you and that started after LDN worsening of your underlying illness beyond a brief initial flare, need for opioid pain medication, surgery, accident, dental work. You need guidance on holding LDN. An unexpected interaction with a new medication, a different doctor prescribed loss of effectiveness if a dose that was working stops working. Otherwise, save your questions for the scheduled follow up. Keep your notes. Trust the process. A note on patience. LDN is not a fast medication. It rewards patience. The patients who do best are the patients who give the medication time, who stay on a dose long enough to see what it does, and who do not change everything at once. For a society used to instant results, this can be hard. Most modern medications act within days. LDN does not. It works the way the body itself works, gradually, in cycles, with progress that is sometimes invisible until you look back from a distance. 3 months from now, you will know more. 6 months from now, you will know more still. A year from now, the picture will be clear. For most patients who respond, the journey is worth the wait. Chapter 13: The Honest Truth About LDN. We have come to the end. Before I close, I want to step back from the clinical detail and tell you the truest things I know about this medication, after 20 years of prescribing it. These are not the things you will read on enthusiastic LDN websites. They are not the things you will read in skeptical medical journals either. They are what I would tell my own family if any of them came to me asking whether to try LDN. Here they are. LDN is real. The science is real. The mechanism is real. The clinical responses are real. After 20 years and tens of thousands of patients, the case for LDN is no longer something a thoughtful clinician can dismiss. It is supported by published trials in major journals. It is being used at academic medical centers. It is being studied in active research programs around the world. If anyone tells you LDN is fringe medicine, they are not paying attention. They may not have heard of it. That is not the same thing. LDN is not a miracle. I have never seen LDN cure anything. I have seen it help. I have seen it transform some lives. I have also seen it produce only modest benefit or no benefit at all. About 2/3 of patients who try LDN respond meaningfully. About 1/3 do not. Of the responders, some have dramatic responses, but most have moderate ones. Pain that goes from a 7 to a 5, fatigue that becomes manageable instead of disabling, brain fog that lifts enough to think clearly again. These changes are real. They matter. They are not miracles. If anyone tells you LDN is a cure for everything, walk away. Real medicine does not work like that, and LDN does not either. The 2/3 is enough. For a medication that is inexpensive, gentle, well tolerated, and easy to combine with almost everything else, a 2/3 response rate in chronic illness is remarkable. Most of the medications we use for these conditions have lower response rates and worse side effect profiles. The patients who tell me LDN gave them their lives back are not exaggerating, even if their lab numbers do not look dramatic. If you are sick enough to be reading this book, the chances of LDN helping you are real, not certain, not high enough to promise, but real. The 1/3 matters too. If you do not respond, that is not a failure on your part. It is not a failure on your prescriber's part. It is a feature of how this medication works. Some bodies do not respond for reasons we do not yet fully understand. We have strategies for non-responders, and many of those patients eventually find what works for them. Some do not. If you are the 1 in 3 for whom LDN does not work, you are still the same person you were before you tried it. You still have options. You still deserve good care. The journey continues. LDN is a people's medicine. I called this book a people's medicine in the prologue, and I want to come back to that idea here at the end. LDN spread the way nothing else in modern medicine has spread. It was not promoted by drug companies. It was not sold by pharmaceutical reps. It did not appear on television commercials. It traveled patient to patient, doctor to doctor, conference to conference, support group to support group. Every patient who improved told their friends. Every doctor who saw it work told their colleagues. The peer-reviewed literature followed the practice, not the other way around. There is something hopeful in this. It tells us that good medicine can still emerge through the wisdom of patients and the curiosity of clinicians. It tells us that not everything important in healing comes from a corporate boardroom or a regulatory agency. It tells us that 20,000 patients sharing what worked for them can move medicine forward in a way that no single trial ever quite does. If LDN had been profitable, it would have been promoted decades ago. Because it was not, it spread the slow way, through people. The slow way turned out to be a strong way. The medication is still here. The community is larger than ever. The science continues to grow. What I hope you do with this book. If you are considering LDN for yourself, I hope this book helps you make a thoughtful decision. The framework is simple. Most patients are appropriate to try. The cost of trying is low. The cost of not trying is missing months or years of better function. If you decide to try it, find a knowledgeable clinician, take the medication as prescribed, give it time, and honor what your body tells you. If you are caring for someone with chronic illness, I hope this book helps you advocate for them. Bring it to their doctor, share it with their family, help them find a prescriber if they cannot find one alone. The patients who do best on LDN are usually the ones with someone helping them navigate. If you are a clinician reading this primer, I hope it adds to your toolkit. The clinical book, Low-Dose Naltrexone, 2 Decades of Clinical Observation, has the deeper science. This primer has what to tell your patients. Both have a place in good practice. And if you are simply curious, drawn to one of medicine's more interesting stories, I hope you found something here worth your time. LDN is one of the more remarkable medications I have used in my career. The story of how it came to be, how it spread, and how it continues to grow is worth knowing, whether or not you ever take it yourself. A closing thought. 20 years ago, a patient with Hashimoto's thyroiditis sat across from me and asked me a question I had never been asked before. I had no idea that day that answering her question would shape the rest of my career. I had no idea that the medication she asked about would become a cornerstone of how I practice. I had no idea that I would write books about it, speak at conferences about it, build communities around it, and sit here, decades later, writing this primer for you. Medicine, when it is at its best, is full of moments like that. A patient asks a question, a clinician listens, a door opens. The next thing you know, you are walking through a place neither of you knew existed. Whatever brought you to this book, whether you are sick or caring for someone who is, or simply trying to understand what LDN is, I hope this book opens a door for you too. That is what I have tried to do. Welcome. Postlog, a note of gratitude. 20 years is a long time to be paying attention to one medication. I want to take a moment, before this book closes, to thank the people who made the work possible. I am grateful to Bernard Bihari, who first noticed what low-dose naltrexone could do, and who kept noticing for decades when no one else was listening. I am grateful to the researchers who have done the hard scientific work, Jared Younger and his team at the University of Alabama at Birmingham, Ian Zagon and his collaborators at Penn State, Wai Liu and Angus Dalgleish in London, and the many others whose published studies have built the evidence base I now rely on every day. I am grateful to the LDN Research Trust, the Central International Organization for LDN Advocacy, Education, and Clinician Training. Their conferences have shaped my own thinking for nearly 2 decades. The community they have built is one of the most generous in medicine. I am grateful to my colleagues, the integrative and functional medicine clinicians who took LDN seriously when most physicians did not, who shared their clinical observations, and who taught me as much as any textbook ever did. I am grateful to the patient communities, the LDN support group on Facebook, the LDN support group on school, ldnsupportgroup.org. More than 10,000 members have shared their experiences, their failures, their successes, and their wisdom. They have taught me more about how this medication actually works than any clinical trial. The questions they ask each week keep me curious. Their stories keep me honest. I am grateful to the journals that took LDN seriously when it was unfashionable, and to the authors who kept publishing through the years when LDN papers were hard to place. Their patience built the literature this primer rests on. I am grateful to my patients. Some of you have been with me for nearly 20 years. You have trusted me with the difficult parts of your lives. You have taught me by responding to LDN, by not responding to LDN, by getting better, by getting worse, by asking hard questions, and by trying again when something was not working. Whatever I know about this medicine, I learned from you. Most of all, I am grateful for the woman with Hashimoto's thyroiditis who asked me about LDN 20 years ago. I do not remember every patient I have seen, but I remember her. She started something. She did not know it. I did not know it either. The path opened the way most meaningful paths open, through a single conversation on a single afternoon with someone who deserved a thoughtful answer. I have tried in the years since to give thoughtful answers to as many people as I could. Thank you for letting me try. Yoon Hang John Kim, MD, 2026. About the author. Yoon Hang John Kim, MD, is an integrative and functional medicine physician who specializes in using low-dose naltrexone to address the root causes of chronic illness. He has been prescribing LDN for more than 2 decades and has presented at multiple LDN Research Trust conferences. He hosts the LDN support group community at ldnsupportgroup.org, along with companion Facebook and school groups that serve more than 10,000 members worldwide. Dr. Kim practices virtual telemedicine through direct integrative care, serving patients in Iowa, Illinois, Missouri, Georgia, Florida, and Texas. He writes for clinicians and patients at yoonhangkim.com. When he is not working, Dr. Kim enjoys writing fiction. He is the author of the fantasy series Chronicles of Elandris,